One.
We are live, sir.
Okay. Good evening, friends. At the outset, I would like to welcome everybody to this webinar on infection control with a particular focus on post-COVID protocol that we need to follow. So I welcome you all. Before we start the presentations, let us look at what we are aiming at. We would like you to get a good understanding of the corona pandemic with a particular focus on ophthalmology. Next, we would like to see to it that we understand how to save ourselves from getting infected. And lastly, we would like to look at the relationship between the quality of our work and the corona epidemic. Friends, before we go on to the presentations itself, we would like to introduce our eminent panelists first, and I request Dr. Amish to introduce Dr. Lalit Verma sir first. Dr. Amish. Dr. Amish, am I audible to you?
Yes. I'll just unmuted myself. Thank you, Dr. Uday, and good evening, everybody. It is a pleasure to be a part of this webinar today, and it's my pleasure to welcome and introduce Dr. Lalit Verma. He is a very good friend of mine, and I have been with him many times. At present, he is the Vice President of the All India Ophthalmological Society, and in near future will become the President. He was the Chairman of the Scientific Committee of the AIOS for the last 6 years, and has been served the society at different levels, including Treasurer, Secretary, etc., for many years. He is working with Center for Sight New Delhi and has been invited to 634 conferences, workshops and CMEs. He has 172 publications, out of which 72 are international journals. He has received 46 awards and orations. He has authored quite a few books and has been a part of, has written 41 chapters in different national and international books. He has been organizing secretary of the 61st annual conference of the AIOS at New Delhi. I know him very well. He is a very good teacher, and I have heard him many times. The lecture that I liked his most was mistakes that we make in ophthalmology. I always appreciate that. A very good trainer. Welcome you, sir. Now I would like to
go ahead.
Now I would like to welcome Dr. DISPOSABLES Agrawal. She is a senior cornea and anterior segment consultant, and is a director and founder member of MGM Eye Institute at Raipur. She has done her fellowship in cornea and anterior segment in LV Prasad Eye Institute at Hyderabad. She has co-authored many publications and is guide of DNB students. She is actively participating in various community outreach programs. She is representing the institute in the state at national and international forum. She has received the prestigious Distinguished Service Award by Asia Pacific Academy of Ophthalmology. Under her leadership, MGM Eye Institute is progressing and serving all segments of society in this region. Welcome, Dr. DISPOSABLES Agrawal.
Thank you, Dr. Amish.
Thank you, Amish. I would like to introduce Our next eminent panelist, a legend in ocular microbiology, Dr. Savitri Sharma Madam. Her specialty is ocular microbiology. She is the Director of Laboratory Services at L.V. Prasad Eye Institute Network, and she is Head of Microbiology at Kalam Anjireddy Campus, L.V. Prasad Eye Institute, Hyderabad. She did her post-graduation in medical microbiology from JIPMER Pondicherry in 1982. She is the Director of the Laboratory Services, President of Ocular Microbiology and Immunology Group USA. She described the first case of acanthamoeba and microsporidial keratitis in India. She is recipient of several grants from DBT, CSIR, and DST. She has conducted several RCTs, randomized controlled clinical trials in contact lenses, endophthalmitis, and keratitis. She has been guide to 7 PhD students, past editor-in-chief of Indian Journal of Microbiology, past president of Indian Association of Medical Microbiologists, past president of Society for Indian Human and Animal Mycologists. She has received 33 awards, including Senior Achievement Award of American Academy. She's authored a book on ocular microbiology and has published 20 chapters in books and 305 papers in international peer-reviewed journals. Her special interest is in hospital infection control, fungal infections, acanthamoeba, pythium, and microsporidial keratitis, antimicrobial susceptibility, biofilm, immune response in the cornea, etc. And she's a very good teacher. Her students remember her very fondly, a very pleasing personality, and a legend in ophthalmology. Welcome, madam. Welcome, Dr. Savitri Sharma, madam.
Thank you so much.
Next, I would like to introduce our another eminent panelist, Dr. Shashi Kumar. He is senior consultant at Kochi Eye Care Center, Ernakulam. Did his MBBS and MS from TVM, past president of Karnataka Society Ophthalmic Society, presently chairman of Infection Control Cell of Karnataka State Ophthalmic Society. He has held various positions in KSOS, including editor of the journal, secretary and treasurer's posts. Is interested in cataract, glaucoma and squint work. Has edited a book on OT and asepsis for Karnataka State Ophthalmic Society, and I suggest that everyone should take a look at that book as a useful tool. He has organized seminars on infection control for doctors and paramedicals at state and national level. I welcome you, Dr. Shashi Kumar, sir. I know him for a long time and will have good inputs from him also. Welcome, sir. Next, I would like to request Dr. Amish to introduce our first speaker. Dr. Namrata Sharma will be joining us a little late, and so we'll request Dr. Jacob Matthews to go first. I request Dr. Amish to introduce Dr. Jacob Matthews.
Welcome, Dr. Jacob Matthews. At present, he is a cataract and anterior segment surgeon at Cochin, Dr. Jacobs Eye Hospital, Cochin, and he is a former chief of phaco and cataract services, clinical meeting group member at Arvind Eye Hospital, Madurai. He has been instrumental in Vasan Eye Care standard protocol for cataract surgery and infection control team, Lotus Eye Care Hospital, DBCS coordinator and director of phaco training, ISO 2000 facilitated DNB and installation of BSc optometry school. He has been working, I know he has been working for a long time in infection control in IoT, and he is a very good friend of mine. Us, I would say, me and Dr. Uday. We welcome you, sir, and we look forward to learning a lot from you. Dr. Jacob would be talking on OPD protocol in this era of corona pandemic. Welcome, Dr. Jacob.
I'll stop sharing my screen, and Dr. Jacob, you can start sharing your screen now.
Can you hear me?
Yeah, sure.
Can you hear me?
Yes, sir. Now we can
Okay.
hear you, sir.
Okay, that's my screen. Actually, thank you very much, Ika, for arranging this meeting, and hope it will be a very useful session for people all around India, because we are facing a huge crisis as it is. In Kerala, this being one of the smallest states in India, actually we had the first case of COVID coming in. That was the first in India as well. And the end of January 30th, we had the first patient coming in, and it was from China. And ever since, during the month of February and the following months, our healthcare system has been quite on their toes with our health minister KK Shailaja, who was very efficient and had the IMA backing, and she actually caught the attention of the international authorities as well for having done such a good work during the first few months. By the middle of May, we had a second wave where huge numbers started appearing all over, and this was probably triggered by the NRI crowd who started coming in from the Gulf. So as it is standing on 14th of September, we have about 1,10,818 cases already, and out of which 72% have recovered. That is 79,813 patients have recovered from it, and we have had 454 unfortunate deaths. And 82% of this in our state is due to community spread. So as hospitals, we run our institutions, I think doctors should be quite concerned about how we'll be able to contain this scourge. So as you can see, there's a regional difference all over India in the incidence, the severity of the disease, as well as the morbidity and mortality has been well documented. And in this particular month, we are actually anticipating the numbers to go up to 5,000 or 10,000 in a day in our state of Kerala. So this shows the electron microscope, transmission electron microscope image of the COVID virus. That is, the blue circles are the virus, and the dark spots in those are the genomes. So this was one of the first isolates that was taken from the first US case of COVID-19. And we actually follow the IMA Association of Physicians protocol, basically. And this is basically to deliver the essential healthcare, taking care of the patient's health, preventing the spread of infection, and to minimize the exposure of the COVID while the patients are walking in to our institutions, as well as the health workers also supposed to be protected. So this is to, the basic aim is to, objective is to reduce the risk of the facility. The system as such should not come to a shutdown. So we should have to take care of the facility as well as the people who are walking in, and also the health workers. And also we should be prepared for the eventuality or the crisis that we are facing by properly gearing up infrastructure and being prepared with gearing up for the situation. So actually we do it in 4 different steps. Even before the patient walks in, we need to plan how we are going to go about doing these things. So preparation of the OPD setup as such, and then as the patient comes in, what all you should take care, and as he goes out, all the while we have to be suspicious about each person who is walking in. So we have to be very careful, and as they walk out of the OP also, we need to make the place sterile before the next few patients walk in. So what is actually followed is we try to fix appointments over the phone, and even while the call is coming in, we try to screen the patient. We ask them from which place they are in, whether they are from a hotspot or a controlled zone, and then we give them an appointment. And even teleconsultation or video consultation is legalized these times, and we can even give the prescriptions over the phone or by teleconsultation. So this can be utilized, and whoever can be treated with the proper documentation and records, we can do it. Thus, the patient is not required to walk in. The stocks should be properly maintained, because initially when this problem started, we had a shortage of masks, gloves, or even the sanitizing materials. So these have to be properly stocked, and we have to look into the pharmaceutical stocks too, so that the right medications are available. And any sick staff is asked to stay back at home. We don't want people who are having fever or cough coming in and causing more problems. So we ask them to stay back. Cross training is very important, so that both the administrative as well as the medical part of the hospital goes hand in hand in preventing the infection or controlling the spread of the infection. All payments can be done online or through cards, so that cash handling is minimized, and you can always post signs or posters outside in the patient waiting area or even outside the hospital, educating the patient and making them aware of the importance of wearing masks. As you would have noticed, most of the patients pull down their mask as they are about to see the doctor or they want to talk. They think it's not polite to have your mask on. So you need to remind them and educate them. Even the staff are taught why it should be done. So this is one of the samples of the posters which you can have. If they're having any symptoms like any of these, then better inform either over the phone or as at the registration site. Then we can properly handle them, so that they don't spread the infection in case of suspected COVID patients also. So being an NABH accredited hospital, we do a lot of documentation, but then at this time we need to have special registers to, these points have to be noted. The patient register where the mobile numbers, the area where they're coming from, and also any referral details are entered there. And any patient who has suspicion of having COVID should be notified to the health authorities, and they should be properly informed and handled in the proper way. And a disinfection register as well as a chart. The chart can be pasted in each department where the disinfection, what time and date it has been done last, and when it should follow, so that we have a record of what is happening. Staff attendance, the register, the date and time, and the area of duty. We try not to mix up the zones, like we limit our administrative staff to the particular area or room or the particular floor, so that they don't come and mix with the clinical staff. And staff training also is an ongoing process in NABH. So here in COVID crisis, what we are doing, that can be recorded and reported through a separate register. Also, the medical personnel should be properly updated, and they should be knowing as to what steps they should adopt to prevent the spread of the infection, as well as how to handle a particular patient if something suspicious is found. And always have the just required number of staff in a particular area. Try not to mix them up. And always a reserve team, a 30% of your staff can be always kept as a reserve, so that if one team falls sick, somebody else is there to take over and the service can be continued. Any preventive measures or health promoting steps can also be taken in the form of vitamin C supplements and zinc. So this is a checklist which you can have, whatever things I've mentioned there. We can, all the supplies, the masks, the tissue papers, the disposal systems, whether everything is in place, sanitizers, all this can be ticked out and make sure that your checklist is right. And as the patient walks in, you should have a elbow tap where the patient can wash their hands as well as their feet before they walk in. And the doors preferably should be automatic doors. If not, it should be kept open so that they don't handle the handles and the knobs. That is very important because this is one surface through which it can most commonly spread. And try to reduce the patient waiting time. In case of ophthalmology, we can reduce it to something like 15 or 20 minutes per patient so that you give an appointment in a staggered manner so that they come in and walk out at the right time. They don't crowd around. Social distancing is very important. When we say that it has to be followed in public, probably hospital is the first place where you should really show the patient what you mean. And stools or chairs without arms would be always preferred. Attenders preferably should not be walking into the hospital. If at all they have to be inside the hospital, we give them a separate zone where they can be waiting, and only the patient is seen by the physician. And if at all something has to be conveyed to the bystander, they can be summoned later on when the patient has walked out. So already mentioned, if a patient walks in without a mask, or somebody who walks in with a valve-like mask, they can be provided the 3-layered mask. We always provide that in the OP at the registration site. Sanitize their hand, check their temperature, and the fee, as mentioned earlier, can be always collected using the card or online system. So as the patient walks in, we keep a staff at the entrance so that they're invited in, and they are provided any help or the mask or any requirement that they have to have. And the attenders, as mentioned, are kept separated in a separate zone. And we strictly regulate the traffic between the waiting area and the consultation room also. I have a small video where I'll be showing what we follow in my place. While examining a patient, especially when taking a swab, throat swab or things like that, always wear a PPE. And also all physicians, it's always ideal to wear a PPE. And at the optometry station, optical dispensing centers, everywhere they wear the mask, the cap, and a face shield to protect themselves. And a barrier is created between the patient and the staff, as they see. All slit lamps have got shields. So if at all slit lamp examination is required, we try best to use a torch and check the eye if it is not something quite serious. But if it's an uveitis or a more detailed examination is required, then check it on the slit lamp, but then always a shielded slit lamp is better. Avoid checking the NCT and applanation as much as possible. And after the patient leaves, all these surfaces are sanitized, including the chin rest of the slit lamp and all equipments that have been used on them. So this is the PP. Already the talks are there regarding all this, so I'm not lingering on that. And hand wash and sanitization, the motions through which, the 6 motions that you have to go through while you're doing it. And each point where you should sanitize your hand while touching a patient or prior to it or even after that is shown here. And once the patient leaves, what should be done? Always clean the surfaces, the table, the chairs, and the slit lamp as mentioned earlier. And regular cleaning after each session would be ideal, like 2-3 hours. You can fog the place, you can clean the place, all surfaces are cleansed, and any follow-ups can be ideally done through the phone or by video calls. So you can ask the patient to call back if they are recovering from the disease that they have come to you for. Then why should they walk in again? So you can reduce the
please
crowd.
Sum up. We are going overboard.
Yeah.
Dr.
Yeah.
Jacob,
So,
please sum up.
okay. This is something I found good in one of my institutions, where I go and do freelancing surgery. It's a nearby town, about 100 kilometers from here. he has got a walk-in channel through which the patient walks through. It has got a sensor. As soon as the patient walks through, sanitizing material is sprayed, the whole body spray is done so that it's sanitized. This is a short video. I'll just finish off with that. So the patient walks in, it's an automatic door. Staff is stationed at the entrance. She does the checking of the temperature, and the mask and gloves all are available there. If the patient needs, we provide that. And we have a form where we fill in all the details of the patient, where they're coming from, the phone number, any illness they have had, any traveling history, especially from outside states or outside the country. And then it's handed over to the reception. You can see the seating arrangement. We have kept a separate zone for the bystanders, and the patients are seated further inside. And one chair apart. We have seen that in most of the clinics, bystanders can also be sitting outside in their cars while the patient is being examined. At the optometry station, we sanitize the optical frames, the trial frames that we use. And these are the workstations where the patient walks in. This is the clinic, how the doctor is prepared to check the patient. And that is the counseling area. And all the staff being donned with the mask, the caps and gloves, including the face shield. So that is the optical dispensing center. And the frames are actually cleansed before they are placed back on the shelf. And even before the trial is done, it's again cleansed and sanitized before it's placed on the face of the patient. So thank you very much for this opportunity. Hope we'll have a wonderful discussion following this.
Thank you, Dr. Jacob. And I request Dr. Shashi Kumar for a quick comments. We are already gone overboard in time, but still, Dr. Shashi Kumar, for your comments.
Yeah, thank you. Thank you, Dr. Dey. Dr. Jacob, you have done a very meticulous presentation. And just two things I need to comment further. One is during the triage, if you have facility, it is better to check the PO2 also, SPO2 also. Because more than the temperature, the SPO2 is better for assessing the oxygen saturation, and which is more important for a COVID patient. Another thing is it is better to switch off the air conditioner. Keep the doors open and switch off the air condition. And another thing is when you are fogging, especially in a state like Kerala where the humidity levels are high, it is better to reduce the water content of the disinfectant solution.
Yes.
Otherwise, you have covered everything. Over to Dr. Ud.
Thank you.
Thank you, Dr. Shashi Kumar, and it was a very good presentation. But I request all the next speakers to maintain time so that we leave enough time at the end for discussion. Next, I introduce our next speaker, Dr. Amish Patel. He did his MS from RIO Ahmedabad and a fellowship in Vitro Retina from Retina Foundation Ahmedabad. He's a solo practitioner in Ahmedabad. He's a diabetes consultant at DiaCare unit in Ahmedabad. His special interest is in conducting workshops on infection control in IoT. He's interested in academics. He was faculty in SSTC for 6 years, TSTC for 3 years, and DSTC for 2 years. He's prepared a video on intravitreal injection technique. He's a faculty for diabetic eye disease at IDF and RSSDI. He has held positions like past president of Ahmedabad Ophthalmic Society and past vice president of All Gujarat Ophthalmological Society twice. I welcome Dr. Amish and over to Dr. Amish now.
Thank you, Dr. Uday. Good evening, everybody. And today I will be talking about the operation theater protocol in today's pandemic era. before I start, I would say that I am not an expert of this coronavirus or COVID, and this is all information gathered from different sources as well as my own personal experiences I will be sharing with you. And there are still a lot of confusions and contradictions. And so we require to change the guidelines every day, I would say, very frequently. So these are a few places from where various guidelines which we have taken care of. And the question today is what is new in the post-COVID era as far as the prevention of infection in the IoT is concerned. So why these changes are required? Uh, this is science of infection control changed. Whether it has changed, I say it has not changed much. Usually we used to have this science, and because as per the situation we have changed a little, that's all. This is a viral infection and our infection control practices should be enough. These changes are warranted because of the fear of mortality. So it is more affecting ourselves and the staff rather than the patient, I think. Of course the patients are also affected and they can also be affected because of the hospital induced infection. So what we have done, what does this mean? That we have tightened the protocol because of the fear of infection and mortality. Infections were occurring even before COVID, but those were not fatal. So COVID-19, the virulence is high, and for stricter version of the protocol, we felt the cost benefit ratio was not favorable. So the cost of every surgery has increased. And uh, what about that unfortunate patient that develops endophthalmitis? And when one patient loses vision due to endophthalmitis, is it not a fatality from ophthalmo point of view? So in non-COVID era also, it is very much required for a good protocol. Is there anything new in the post-COVID protocol? From my personal view, nothing much has changed, and only thing that the cost factor has increased. Uh, what would be our protocol in the new normal? We need to take a call. Can we afford the higher cost? And it is definitely qualitatively better. So what we need to know is how to work. A new protocol has to be prepared and followed. We should know how the patient is to be prepared, the personnel, the hospital staff has to be prepared, instruments, and what changes are to be made in the operation theater, what changes are to be made in the etiquettes, how to monitor and train the staff. In the operating rooms should have minimum essential staff and should document names of entire personnel in the working in the operating room at that particular, during that particular operation. The OR is to be cleaned between every patient. See, especially in trust hospitals or where the volume is big, hospitals, institutes where the volume is more, and we do a lot of surgeries, the number of surgeries per day have to be decreased, and there should be only one per patient in one OT at a time, and there should be a gap of at least 20 minutes between the two. The OR is to be cleaned between every patient, and like we have to change the bed sheet, clean the head and floor, etc. with disinfectant, clean microscope caps after every surgery with 70% alcohol wipes, and phaco tips and sleeve are to be changed after every case. A gap of at least 20 minutes is to be maintained, and separate dedicated OT for general anesthesia is to be given. Preferable, there should be a provision opening the doors and with feet or elbow without touching the handles. Dedicated doffing area should be provided, and all health professionals, OT staff should wear appropriate dress, including the anesthesiologists, surgeons, nurses, technicians, and housekeeping staff. Taps in the scrub area should be hands-free. Only essential items inside operation theater. No extra items are to be kept inside the operation theater. Only single patient to be operated at a given time. Separate linen and all disposable items are to be used separately for all individual patients. At the end of the day, deep cleaning of the entire operating room is to be performed. Any linen used to be carried to the laundry in a closed trolley and disinfected with dilute sodium hypochlorite before washing. Uh, I will not go into much details of AHU because Dr. MS is going to talk about the infrastructure, but air handling unit is a better option. All surgeries are preferably to be done in a daycare. See, because in certain trust hospitals or government hospitals, they keep the patient overnight, but daycare would be a better option in this era. In the event of COVID positive patient, when such a patient comes, the surgery should be deferred as far as possible, and if not, then it should be operated in a COVID approved hospital only. Uh, there are certain institutes that do SICS, manual SICS also. For them, block room, the physical distancing is to be maintained, and the patients should wear a 3-ply medical or surgical mask before entering the room. Keep minimal vocalization and movement and uh, communication. Only whatever is required is to be done, and that should be also at a distance more than 5 feet. The couch is to be disinfected after every patient with 70% alcohol swab or 1% sodium hypochlorite solution, and change of gloves after every patient is to be done. In the OT, when there is a small or a solo practice setup, one surgery per day, because we don't have that much of volume these days, and we can extend our surgeries to every day for all weekdays. Or if the volume increases, we can increase it to 2 or 3, but keeping a gap of about more than 20 minutes between the two to give a breathing time and cleaning time of the OT. Only necessary things are to be inside the OT. Patient and personal guidelines would be the same. May avoid general
Dr.
anesthesia
Amish,
and
please
COVID
sum up.
positive patients. Yeah, just a minute or two. OT time slot is to be separate for all from the OPD, and patient to be admitted for a minimum possible duration. Proper post-op care of disposables and instruments and linen to be done. Uh, I'm not going into much details of this, but clear used linen immediately after the surgery, put them in a closed bag or trolley and disinfect it with sodium hypochlorite, can sterilize them. What I do is I sterilize all my instruments and linen again immediately after the surgery, and then send them to wash. Cut all the disposables and wastes immediately after every surgery and put them in a closed disposal bag, disinfect it with sodium hypochlorite, and then put it in another bag for clearing in biomedical waste. The personal, nothing is allowed like this. A good foot wash is required. The surgeon and the scrub staff, OT dress, cap, mask. I will just the donning procedure: first, second, third, fourth. The first OT dress, then cap, shoe cover, and 95 mask. We always prefer double mask and double gloves and a face shield or glasses. I don't think that a PPE kit is required. Removing is like this. Gloves, the first gloves are to be removed, then face shield or glasses, triple layer mask, then cap, shoe cover, OT dress, gloves, second gloves, then give a hand wash and 95 mask, and then wash of hands and neck is to be done. This is the CDC guidelines, how it's almost the same what I was shown. And this is a scrubbing technique. We all know about it, and we have to take care of these areas of the hand while we scrub. Unscrubbed staff, OT dress, cap, and double mask, gown, gloves, glasses, face shield, slippers. Should be something like that, and the hair is to be covered by the cap, and the nose is to be covered. This is very important, and I would like to ask the esteemed panel if this is required and if this is comfortable, especially for the operating surgeon. A lot of people are using it. I don't know. I'm not aware of it. I haven't used it. Human resource management is very important. The times and the patient should be considered important source of infection and treat them as an individual patient, individual case. And again, the patient is to be having using mask, cap, gown, disposable things are to be provided to them, and we all know about this. The risk of surgical mask to the patient, uh, there can be, it can press over the nose of the patient. The patient may cough or sneeze and make the mask wet, and it can be produce discomfort to the patient, and the patient may move the head or may not be that much cooperative. When we operate under general anesthesia, it has to be the last surgery of the day.
Dr. Amish,
One
please
patient in
finish.
a one for general. Okay, fine. And COVID positive patients should be treated separately with a PPE kit. These are a few important take-home messages which I'm skipping. And
Okay, thank you, Dr. Amish. And now I request Dr. Deepshika Agrawal, madam, to give a few comments on take-home messages from this presentation.
Dr. Amish Patel has presented very well, and he has explained everything in a detail of OT protocol. As all we know, the OT operation theaters are the heart of the hospital, and those are the main nearly 80% revenue generating source to make the hospital self-sustainable. So as he has rightly said, all we are very much concerned, we have to take care of COVID-19, that is for the patient as well as for the healthcare workers. So in this, I would like to, like he has covered almost all the points, but I would like to say in especially operation theaters, because this is new, some changes which we are doing. So those all we have to follow the universal protocols, but because there are the regional differences, so we can make something like changes customized, which are the according to the need. And second one is important, like we should like focus on OR surveillance, daily OR surveillance with the checklist related to the COVID. So we will not miss any this point which we are missing. So thank you very much, Dr. Amish. It was very well covered.
thank you, madam.
Dr. Uday, one point you see which is very controversial, are all
Yes,
the
sir.
patients getting COVID test done before they enter the operation theatre?
Very true.
That has not been brought out.
Right. What is your opinion, sir? Is it required?
So what we at Center for Sight are doing, all GA, yes, all plastic surgery, yes, all long surgeries, VR surgeries included, yes, cataracts, no, injections, no. So that is what we are following, because it is the duration of contact also, how much
That's right.
it stays inside. Ultimately, it is the
It
load,
really
viral load.
depends on the
Because the
duration
viral
of
load, the
surgery.
more the patient stays inside and more he talks, more the chance. I'm sure Dr. Savitri madam would agree. Therefore, in the OPD also, we hardly talk. We, as soon as bare minimum is done, we ask him to, go or call up or telemedicine or whatever. So
Yeah, I think
Usually it
in
reach-
OT,
suppose the patient is a has a virus in, because all patients should be treated as if all entrants should be treated as if
COVID
they're positive.
COVID.
So,
May I add a word?
yes, madam.
Yeah, I agree. All these days we are worried that when we do surgery, patients should not get infection, and we were taking care of all the things were actually centered around that. And now we have the opposite situation, or not really opposite, but added to it, that we should not get infection from the patient. So
Yeah.
putting
No, my
mask on the patient.
Savitri, my patient asked me, he should not get infection from me. Because he says, doctor, you tell us to get COVID done, have you or your staff got it done? So that
You give your report to us.
I
So I
think
think testing the patients who might be, we might be vulnerable to, like GA patients, plastic surgeries, or aerosol generating type of surgeries. We need
absolutely,
to
yeah.
identify those, and those patients can be asked for getting a test done and then come to us.
Yeah,
no. What
Those
about
that require more than 30 minutes,
yeah, yeah.
I think they require to go for a COVID test also.
I agree, Amish. Amish,
And
this
that too
point is absolutely well
RT-PCR.
taken, that any patient
Yeah.
requires more than half an hour of surgery, because the
Half an
contact, because we have to draw a line somewhere. Somewhere to draw a line.
Yeah.
Like I get it done for all VR procedures. All, like madam was saying, wherever there's an aerosol possibility, like GA 100%, plastic 100%, then VR surgery 100%. Cataract injections we don't do it.
So, sir, if I may share the protocol that we
We
follow
also
at
don't
RP
use.
Center, we are doing RT-PCR for all cases, even if it is a collagen cross-linking, even if it is a cataract, even if it is the moment the patient enters the OT, we are getting a RT-PCR done, even if it is a EUA. The only problem is that what about the personnel who's there in the OR itself, like, technicians, like attendants, OT attendants, like housekeeping staff. We don't know what is happening with them, and they could be
The
carriers
issue,
also.
the issue there is that for how frequently you can get it done, because the validity of RT-PCR will not be for more than few days. You can't do it every week on these
Yeah.
personnel also.
So even for the patients, we have a protocol that they should the report is valid for us in our OR only for 72 hours. So if the RT-PCR is negative, say 4 days ago or 5 days ago, then our OT nursing staff doesn't take the patient. So it's, become like that. So now we are not respecting the units also that, our OT day will come on this particular day, so we'll operate. As soon as we have a RT-PCR negative, we just take the patient up irrespective of days, because we don't want the patient to undergo RT-PCR again and just do the surgery. So that is the thing. But I think all of us need to be careful about the
But
other
Namrata, you
people
see,
part.
Namrata, if this is a guideline, that is not practical that all patients should have RT-PCR.
It
Because
is
when
not feasible. Yeah, it is not
yeah.
feasible for
So
everybody.
maybe
But
you do it, or Uday does it, but as a pan-India level, this cannot become a guideline.
It's not possible.
it's not possible.
Anyway, the discussion can go on later. Let us proceed with the talks, and I welcome Dr. Namrata Sharma, madam.
Yeah.
She was busy with meeting at RP Center, and now that she has joined us, I welcome you, madam, and
Thank you.
let me quickly give her introduction. Professor Dr. Namrata Sharma is working in cornea, cataract, and refractive surgery services at Dr. RP Center, AIMS. She did her fellowship from Moorfields Eye Hospital, London. She is presently Honorary General Secretary of All India Ophthalmological Society. And if I am not wrong, madam, you are the first woman secretary of All India Ophthalmological Society. She is Regional Secretary of Asia Pacific Academy of Ophthalmology, and she has 2 patents to her name. She has won many international accolades, including Senior Achievement Award, International Ophthalmologist Education Award, RANSCO, and Best of Show Awards 6 times at American Academy. She has won Best Video Award at ESCRS. She has won Leadership Award and Achievement Award at Asia Pacific Academy of Ophthalmology. She has more than 450 publications in international peer-reviewed journals. She has authored 11 books, conducted several instruction courses at international and national platforms, She was the principal investigator in many multicentric international FDA trials and randomized controlled trials, which have changed the clinical practice. In addition to all this, what I admire very much is at AIOS, all our office bearers have been very active right from the beginning of the pandemic, and they came up with a protocol for all of us to follow. And I congratulate them for what they have done. They've kept an eye on the international developments and shared the same with all of us in the country. I welcome you, madam, and I hand it over to you for your talk, madam.
Thank you so much, Dr. Uday Gajiwala. It is an honor and a pleasure to be presenting here at this forum. And I would be talking to you about paradigm shift in the COVID era. So I think you've already heard about the protocols that have to be followed in the ophthalmic practice. And as we come down on the timeline for the COVID-19, it was on December 31st, 2019, and this is important that it was in 2019 and last day of 2019 that Chinese officials informed WHO that 27 cases of pneumonia have been reported. On 7th January, this was found to be due to coronavirus, and it was named as coronavirus 2019. And first novel coronavirus patient in India was reported from Kerala on January 30th. And on February 11th, it was called as COVID-19. And basically, it was coronavirus infectious disease 19 because it was in 2019. So on March 11th, COVID-19 came to be characterized as pandemic as declared by the WHO president, by the WHO themselves. And then ICMR expanded the definition of the case for COVID-19 and included those patients with symptoms even if they didn't have recent travel history or they were not known contact, which might have transmitted the virus. Then 50 days after the virus was first reported from India on 22nd March, Janta curfew was declared, and subsequently a nation-wide lockdown was imposed until April 14th, 2 days after this Janta curfew. And on 28th March, there were more than 1,000 confirmed cases, and India had already entered third stage of the pandemic, that is community transmission. And on April 14th, 10,000 confirmed cases were recorded as the nationwide lockdown, which was further extended to May 3rd. Now, then this lockdown was opened, and phased reopening was started on June 8th. And even as we unlocked, we had 2.5 lakh cases and 7,200 deaths. So when we started, we had 600 cases and 10 deaths. And even after, as we unlocked, the number of cases had increased. Now, earlier, the ICMR strategy was that we should test only those who are direct close physical contact of laboratory confirmed positive cases or history of travel in last 14 days to high-risk COVID affected countries. But as the COVID became more and more rampant in India, even the symptomatic individuals, as well as the asymptomatic direct and high-risk contacts were also told to be tested, tracked, and isolated. Now, initially, the advisory on the use of hydroxychloroquine was given as prophylaxis for COVID-19, which came on 23rd March 2020. And revised advisory was issued on 22nd May 2020 because there was a study which was done at AIIMS amongst the healthcare workers, which found anecdotally that chloroquine did have a role to play, and it was beneficial in healthcare workers. Now, another landmark thing that was allowed by the government Ministry of Health and Family Welfare was that the drugs was allowed to be delivered at the doorsteps to the consumers. And they allowed the retail sale, which was again a big thing because it had not happened earlier. And this was done in public interest. So the retail drugs were allowed at the doorstep of the public. Another thing which came into being was the insurance scheme for the healthcare workers fighting COVID-19, which was implemented from 7th April 2020. And the scheme has got extended for a period of 90 days from the original period on 7th August 2020. So there is 90 days more extension on that. Now, advisory for managing healthcare workers working in COVID and non-COVID area of the hospital. First advisory came on 15 May 2020, and it said you have to shut down as soon as you detect a case of COVID, you have to shut down and sanitize the hospital. And then this was revised further on 18 June 2020 that you need not shut down the hospital, you have to sanitize, and the asymptomatic healthcare workers can continue to do work, and the hospital can continue to run. Then there were a lot of consent forms which came, COVID-19 pandemic emergency treatment consent forms, and then also ophthalmic treatment consent forms as well. And there were revised guidelines for the clinical management protocol, which was given of COVID-19, which came at these various dates, which have been shown in the third week of June up to the first week of July. Guidelines for ophthalmic practice were released by the Government of India. Version 1 came on 8th May 2020, and version 2 came on 19th August 2020. And they further said initially only emergency services were started, and then they allowed the starting or commencement of the routine services as well. Now, again, the guidelines were released for COVID-19 ophthalmic practice, and earlier no outreach camps were undertaken and no mobile vans to be sent in the field as far as the community community ophthalmology was concerned. But now this has been allowed with few precautions. Eye banking continues to be on its lowest, you can say it's at its lowest form now, because only HCRP is allowed, that too in areas which are not infested by COVID, in non-containment zones, and voluntary eye donation by Government of India is not yet allowed. The pre-surgical COVID test on patients is not mandatory, and teleophthalmology and teleconsultation practices are to be explored and encouraged, especially in difficult areas. And again, this has again changed not only the face of ophthalmology, but the face of whole of medicine across India. Now, clinical guidance for management of COVID-19, and this is more when our healthcare workers, our own ophthalmologists, they have COVID-19. Now, earlier, in the case of mild disease, what is recommended is home isolation. For moderate and severe disease, the drugs which have been approved are intravenous steroids as well as remdesivir. So these are the two drugs which can be given and should be given in moderate disease and severe disease. And plasma therapy has been left at the discretion of the physician oblique the treating anesthetist. But there have been recent studies to show that plasma therapy doesn't help. So the thing which people are now advocating in moderate diseases, that immediate hospitalization, oxygen itself is a therapy for this disease. Injection remdesivir, which is given 100 milligrams IV BD on day 1 and then daily for 5 days, and intravenous steroids. And of course, one has to monitor the oxygen saturation levels, the fever, and the symptoms. Advisory on the strategy for COVID-19 testing in India, which is recommended by the National Task Force, is this. So you have to get a rapid antigen test done. If it is positive, it has to be reported as positive, irrespective of the symptom status. But if it is negative and the patient is symptomatic, then definitely RT-PCR sample goes. And if the patient is asymptomatic, and if the individual turns symptomatic, then you have to repeat the test either by rapid antigen test or RT-PCR. So this is the guidelines as far as the COVID-19 testing is concerned latest. Arogya Setu app has again has come up in a big way for contact tracing, syndromic mapping, and self-assessment in all major government areas, even in areas, private institutions, airports, etc. Everywhere you have to carry this. Remote appointments via telephone and videos have been the biggest shift in the care model during COVID-19 series. Innovation has occurred because people have now started keeping the data on the cloud so that this can be referred to. And we came out with the guidelines from AIOS, which were issued on 11th May 2020 as a result of meetings of 225 plus experts with 20 Zoom hour meetings with 13 societies. And these are just glimpses of some of the meetings, including all organizations or societies, subspecialty societies which are there in India. Experts were called, and representation was taken not only from the major hospitals in India, government institutions, corporate hospitals, group practice, solo practitioners, across all strata of the ophthalmic practitioners, whether in small towns, rural areas, urban areas. It was kept in mind that each of these guidelines had representation from all of them. And we also involved the Ministry of Health and Family Welfare, Government of India officials, Vision 2020, NPCB, so that there is some sanctity to the guidelines. And in each of these practices, we came out with guidelines. Of course, this is a dynamic document which keeps changing. It is on the AIOS website as and when the COVID situations and the ophthalmic practice evolve. So it's a 104-page document, comprehensive document, which has also been sent internationally to all over all the societies, and the International Council of Ophthalmology has also adopted the same, and several other international societies have also referred to it. The education way we educate has changed, imparting knowledge through webinars. Experts we are able to get across the globe, international, with usage of multiple social media platforms like YouTube, Facebook. This webinar itself is a example of the same, and it is free for all. The way ophthalmic conferences are happening internationally and probably in India is virtual. So WOC, AAO, ARPOS, ESCRS, ASCRS, everything was virtual. And I think this is going to be the new norm, at least for the coming next year or next couple of years. And turning to telemedicine is the main thing which has happened. Pandemic has rewritten the future of healthcare now, and telemedicine practice guidelines have been released by Medical Council of India and has been legalized as on 25th March 2020. So again, we did try to work out on telemedicine platforms, and 4 or 5 platforms have already been shortlisted through the AIOS, which you will be informed, so people can use this telemedicine platform. There's another consent for telemedicine services. So to conclude, change is the only constant. We have to constantly keep changing. Ophthalmology doesn't change, but the way we practice ophthalmology, why ophthalmology, our own lifestyles for everything has changed, will change until the vaccine comes, which it seems will take some time to come. Until then, we will have to live like this only. And thank you very much for your kind attention.
Thank you, Dr. Navrata. And I would like to request Dr. Lalit Verma to give his expert comments on.
Thank you, Namrata, for giving a very lucid kind of presentation. The only, all these guidelines are available on a website. The only thing is that things have been changing. It's a dynamic thing. And whatever government advisories or guidelines, believe me, since March till now, they've always changed. So therefore, we cannot enforce any particular, sentence. Even things like isolation, things like hydroxychloroquine, things like whether shutting down of clinics. So everything has taken so much salt every time. So I think there always has to be a balance between the life versus livelihood. So now that it has opened up, although the cases are increasing tenfold every day now, but they have opened up everything, meaning thereby we are now depending on herd immunity rather than any medicine. You see, the theories have changed. Now steroids because of cytokine storm and remdesivir only for a few days is required. So this has become the change now. So there has been a paradigm shift virtually every month. What Namrata also stressed, that these are dynamic and the best is yet to come actually. So we are all waiting for vaccine. I personally don't think so that vaccine will do any miracle. What will ultimately come down is the herd immunity. And I think India is fortunate. I think Savitri can make a comment there to have, I think, a lesser, mortality compared to US and Brazil and other places. We have been fortunate from that angle. And regarding hydroxychloroquine, I think in the initial March, April, I think everybody of us took it. But now, nobody is, except for the people who are exposed in the COVID wards and all. Otherwise, people are not recommending it. So we have to keep a wait and watch policy. I personally think from the precautions point of view, what Amish was saying, double gloves, double mask, these things, because it's an aerosol ultimately. Remember, it's an aerosol. And the fomite transmission is not a very great kind of modality unless you keep touching everywhere. You see, we are overemphasizing fomite, and you see, best is that double mask and double gloves, as long as you don't touch things, will become a new norm actually.
Okay, thank you so much, sir. And I request Dr. Amnish to introduce our next speaker, Dr. M.S. Ravindra.
It is my pleasure to introduce a very dear, close friend of mine, Dr. M.S. Ravindra. He is the chairman of medical and the medical director of Karthik Netralaya, Bengaluru. He is a managing trustee of the Foundation. He did his Netralaya and fellowship in cornea from Rochester University, USA. He has been working extensively on infection control, especially he expertise in the infrastructure and OT layout, and he has been always a friend, philosopher, and guide to me. A very, I have learned a lot from him, and I would like to welcome him to give his presentation. Welcome, Dr. M.S. Ravindra.
Am I audible now?
Yes, sir.
Yeah, you can share your screen.
I'm sorry.
Hello, dear friends. During
Sorry, there is.
Not
that
able
visible?
to share the screen.
Yeah, I am. Now I'm. Is that clear? Is it visible?
Yeah. Now we are able to see your
Fine.
screen.
I'm sorry for the little delay, hiccup there.
Yeah, no.
And ever since we started our hospital about 7-8 years ago, I've never done so much of changes as was necessary now. Number one is, as has been stressed already, cleanliness and hygiene is number one everywhere in the hospital, from top to bottom, especially in the toilets and wherever the people walk, it has to be kept clean. And all the instruments have to be covered. There should be a barrier between the consultant or the technician and the patient by plastic partitions that you're all aware of. These are the changes that I have brought, and patients are totally unaware of whatever high amount of cleanliness you're going to keep, whatever amount of hygiene education you're going to do. You cannot change the mindset of the patient. So we'll have to be extra cautious as far as hygiene is concerned, especially as was told, the cleaning processes of the floor, chairs, and all is happening 3 to 4 times in a day. And in the meantime, what we have done is we have tremendously burdened the green philosophy of our world, and we are producing so much of waste. And whenever whatever changes we are implementing in the hospital, we should always keep in mind that we should not burden the thing. Everything has to be done. COVID is killing people, but there are so many other diseases which are killing it, and we should not be really worried about the the parameters about N95, N95, N99, all those things. They are supposed to be the best of them, but most of them, I would say, when I assess the people, 60-70% of the people, the masks don't fit their contour of the face. It's a waste. You are protecting, all right, but the air is not getting filtered. Air is coming out unfiltered from the side. If you're talking to a person, you have to talk from front, so that the unfiltered air is coming from all over, and it's a waste. What I do is I use a surgeon's mask, tape all around, all around, and I wear a glasses. And when I breathe hard, it should not fog my glasses. That's the test I do. It should not fog. If it is fogging, that means you're leaking. So I would prefer to use a surgeon's mask, tape all around. On the top of it, I would put another mask and stick that also with the tape. And this is transport tape, or a tape which actually fixes to the skin very nicely. And that's the one which you have to, I don't wear N95 at all at any point of time. Cloth mask is also good. Any mask is good, but then it's not filtering 100%. You're all aware of that. So all masks are made of polypropylene, and they should not be re-sterilized. They should be discarded, but you can always dry them and use it in a cycle of 3 days, 4 days time. And hand hygiene is very important. Before you enter any chamber, either your OT or this thing, you'll have to keep your hands absolutely clean. And that's the OT operation theater. We have done some device. It's a 1-inch plastic pipe. The patient is going to lie down there. And this plastic pipe is connected to the return air ducts of my operation theater AHU. And the moment patient lies down there, and the air is under the drape is not airtight, but there is a negative pressure around the patient's face, so it goes into the air exchanges we have increased, so the positive pressure inside the eye, inside the operation theater, we have reduced the positive pressure, and the air comes out from here, from the OT, it comes out here, it gets filtered through the AHU, and then gets cooled and goes inside the OT. There is a cycle of about 32 times in an air percolates down from here, and we have fixed a UV light, so whatever air that comes down also gets sterilized by UV light. It is said that UV light can kill the viruses in 30 seconds time, and hopefully whatever air that comes, there are many filters here. If at all there is something remaining and passing through the HEPA filter, which is at the end, that also gets killed. The other changes, this is the UV light I'm telling you. This UV light can be put on in between patients. The entire floor is cleaned with hypochlorite solution. And then we put on UV light. We spend about 10 minutes, and next 10 minutes later, we'll shift the patient. We don't keep for 20 minutes because UV light can kill in few minutes time. So the changeover time is 10 minutes in our case. For 10 minutes, it's kept closed. And other areas are also clean. The patient comes with this kind of mask, and we have completely stopped all the aerosol producing procedures, and we just extra cautiously clean this skin around the eye. And after, the most important thing is aerosol, this area which there is a negative pressure under this. If at all some air comes out, this has to be well sealed so that air doesn't come into the surgical area. Soon after that, any basket you can take, or there are special containers which I'll show you. All the instruments has to be the assisting nurse who wears the proper glasses. She puts everything there, and all these are discarded. And this goes to the patient drapes which we cover the patient, and table trolley comes to hypochlorite solution. She herself carries them and puts in hypochlorite, because hypochlorite gives chlorine. This is covered by a lid. The moment she puts it, some other person comes and covers it. And in hypochlorite, it remains for 5 minutes. This is 0.5% for hypochlorite solution. And after that, she bring the instruments and keep it in hypochlorite. Before it is handled by anybody, it goes into hypochlorite, lid is covered so that gas doesn't come out. And then after that only, she starts shifting it to ultrasound and washes it the regular way. These are the trays which are commercially available, and instead of the trays which we used initially, we use these now. These are well covered airtight trays which are available commercially. These are 4-liter trays which amply, if it takes one set of instruments. The water that comes out, washes, go through sodium hypochlorite, and then only it's drained to that. Any instrument that is washed should not be kept wet. It should be dried. And in our hospital, we have a philosophy of autoclaving it on the same day. If there are no surgeries tomorrow, we at least go through a cycle of autoclaving and see that the wetness, if the instrument is kept wet, fungus will grow on it. Doffing is very important. First, you'll have to remove the clothes, and then only remove the, you should not touch the mask, keep the mask on, and glove is removed at the fag end. Autoclaving has to be proper. Let me not go into the details. Documentation has to be proper. All areas in the operation theater, we have fan filter units. This is a place where we give Avastin, or this is within the OT, a corridor. And we have fitted even there fan filter units, which circulates, basically it takes the air, circulates it through the HEPA filters. Sodium hypochlorite comes in 10% solution, what is commercially available, though it's not mentioned there. It's got a strong chlorine solution, it can be 0.5%. Generally, what they recommend is 1%. 1% is too harmful, too toxic. It gives too much of chlorine outside. For ophthalmic work, where we're not dealing with COVID directly, though presumably we treat chlorine, 0.5% is adequate. 10% diluted 20 times is 0.5%. It's got 5,000 ppm. Even this is very strong. In food, they use 0.02. This is 20 times more diluted than that. And so it can be, it depends upon the instrument. What we use is 0.5%. For instruments, we use 0.25% and keep it for 5 minutes. 5 to 10 minutes is the contact time. Viruses can get killed in 30 seconds. You don't have to wait for 5 minutes. In 5 minutes, everything gets killed. Do not mix with this thing. Traditionally, we wash with soap and then the hypochlorite, but in COVID era, the first thing is it goes to hypochlorite. Anything that comes out from the operation, there it goes to hypochlorite, then only it is handled. So waste disposal has to be perfect. Food switch has to be covered, and don't panic. The lot of panic is there, and there are deaths which we keep seeing, which are being highlighted, but deaths were occurring even before COVID era. So I would, we have gone back to normalcy, though the patient arrival is much, much lesser, but we have gone back to normalcy. We all work full time and we take certain precautions, but we don't have to really worry about the COVID. Keep your health very good. That is much better, a safety factor. And in the fear, what we are doing is we are dumping junk into the everywhere. So this polypropylene, all masks are made of, all caps, all leggings, everything is made of polypropylene. Is because everybody is worried about COVID. They just discard it here and there. And a lot of, you can see the hospital waste is everywhere. So we'll have to be more cautious. I would personally say that safe recycling of material is much more important than using and wasting material. Thank you. Yeah, that's my presentation, and I'm.
Thank you so much, sir. Yes, Amish.
Yeah, you carry on.
No. I would like to invite Dr. Parvez to give. Dr. Ravindra has remained very, very practical, not going into so many structural changes that has been suggested by some people, because it won't be possible for everybody to make those changes. Dr. Parvez, please.
Yes, sir. Thank you so much. It was a fantastic presentation, Dr. Ravindran, sir. And definitely every organization is having some limitations, but you have done your best. Only, I think, 2 doubts I have, or 2 comments. Number one, that using of ultraviolet irradiation, it's having some health effect. So generally in an open way, it's not recommended. And number 2, that you are using a negative pressure through one tube, which you are putting under the sheet. When patient is exhaling, that breath is going out. So we have to ensure that exhaust air should be also treated before sending into the environment. Thank you so much.
Dr. Jagdeep Kakadia will be able to comment upon your first comment. Dr. Kakadia, sir.
Yes, sir. Probably ultraviolet has been the most misunderstood energy which we have as a weapon in our hand. And most of us have actually not opened our mind to the right use of ultraviolet, and that's why the comment. Ultraviolet C, the UVC, has not been shown to cause any carcinogenic changes. There are 3 types of ultraviolet light, UVA, B, and C. UVA does not induce carcinogenic changes until a person has a continuous cumulative exposure of more than 80,000 hours. UVB 300 to 310 nanometer is the only wavelength which induces skin carcinoma, basal cell carcinoma of the skin, and that too in a person who is non-melanotic, that means the albinotic or the Caucasian races. UVC light does not penetrate beyond 15 to 20 microns of the human skin. So there is no risk of using UVC except that if the exposure is more than 17 minutes in a day for a person, he may have epithelial burn and he may have a peel off of the superficial dead skin after 2 days or 3 days. And as Dr. Ravindran has said, it's only 30, it's not even 30 seconds, it's only 14 seconds. In a room of 10 feet by 10 feet size, if we put a 36 watt UV tube, it takes only 14 seconds to kill coronavirus. So in my hospital, we have installed, which I'll be showing in my presentation, we have installed 65 tube lights all over the hospital everywhere, and we have set the timers that every 10 minutes the tube goes on for 20 seconds and then it switches off. So that cycle goes on throughout the day. So UV light actually is the weapon which we have to explore, and even in Raj Sabha and even in Lok Sabha now they have installed the ultraviolet lights.
Thank you so much, sir. Thank you for your comments. I know you can go on talking about it so much more in detail. Because of the time constraint, we'll move on to our.
I wanted to add something, just one line.
Yes, please. Go ahead.
I have made a UV sterilizer box of by myself, and we are sterilizing everything like keys and glasses and even the trial set glasses, everything we do it for about 30 seconds. So we don't require anything else to sterilize in the OPD. That is a superb box and we are using it regularly.
Okay, thank you. Thank you, Dr. Amish. And we move on to our next speaker, Dr. Parvez Ahmed, basically a consultant pulmonologist at Dehradun, Uttarakhand. He has many degrees, including a management degree in hospital management. I don't want to read out the whole list. He is international surveyor for ISQUA, IS quality, I believe. Principal assessor and training faculty for NABH and Quality Council of India. Planning and designing expert of hospitals and healthcare. Is an adjudicator for Asia and India Book of Records. Is ISO lead auditor. Is instructor at FCCS USA, one of the degrees that he holds himself. Is a medical legal expert and is joint secretary and treasurer of Indian Chess Society UK chapter. I welcome Dr. Parvez Ahmed. It was my pleasure working with you on developing the guidelines for Quality Accreditation Institute. And I have requested him to talk about the ISHRE guideline. Basically, ophthalmologists by and large are not aware of the air conditioning requirements, and that's the reason why he is invited. Over to you, Dr. Parvez. I'll stop sharing my screen. Thank you.
Thank you, sir. So, Jai Hind, and thank you so much. I would like to extend my sincere thank you to all the organizers for giving me this opportunity to talk about ISHRE guideline. And ISHRE guideline, it is apex body who's making a guideline related to HVAC. Although it is a very complex and vast topic, but I will try to explain in a simplified way. So ISHRE guidelines talk about in general patients areas, OPD areas, doctor's chambers, clinics, waiting rooms, general IPD ward, specimen collection areas, cafeterias, pharmacy, diagnostic centers, etc. to maintain the humidity, temperature, and maximize ventilation is the best approach to limit the risk of COVID-19 infections. ISHRE guideline also emphasized to maintain the temperature between 24 to 30 degrees Celsius and relatively humidity to be maintained between 40 to 70%. The clinics which do not have air conditioning should have provision for good ventilation by ensuring fresh air intake through windows or other openings. In addition, providing exhaust fans in room or adjoining toilet is also recommended by the ISHRE guidelines. The location of intake air and exhaust should be such that air passes through the room. For example, if we are having a 100 square feet room, so to achieve a good ventilation or a natural ventilation, we should have a 20% opening in the room. Relative humidity is very important. Relative humidity affects the infectivity of virus through the respiratory route. When we breathe dry air, that mucous membrane of the lungs become dry. The fluid overlining the cells become more viscous, and the little hairs, so-called cilia, which protect our lungs from deep setting of viable and non-viable particles, cannot work, and particles settles more deeply into the lungs, hence causing infections. So considering all things, the relative humidity level of 40 to 70% to be considered. This is the through slide I have taken through one ASHRAE guidelines. So you can see that bacteria, viruses, fungi might show up to 30 to 40% humidity, they are more active, and above 70 to 60 to 100% humidity, again they are more active. So we are getting a window between like 40 to 70%. So this is the safe window where we should continue our relative humidity to be maintained in our healthcare settings. Temperature directly related with the comfort level of healthcare providers as well as of the patient. So ISHRE recommends temperature range of 24 to 30 degrees Celsius for comfort conditioning. In case of use of personal protective equipment, which we are using in our ICUs or operation theater related to coronavirus, the temperature lower than 24 degrees Celsius may be kept to ensure sufficient dissipations of heat released from body through heavier clothing. Comfort temperature is generally considered between 24 to 30 degrees Celsius after accounting for air velocity, relative humidity, and clothing. A lot of healthcare settings are using window and split ACs. So as we know that window and split ACs are a purely recirculating unit. They develop convenient pockets for developing microbes as well as bacteria. So recirculation of air through room air conditioners must be accompanied by outdoor air intake through mechanical fans or slightly open windows or doors and exhaust using a fan. The location of the exhaust fan and the intake of the air should be such that the air passes through the room before getting exhausted. You can see that I don't have a pointer. You can see my cursor. If this is the room, one side is window, so another side the exhaust fan can be installed. So air is entering through the one window or through the door, so passing through the entire ward and going out through the another corner. So we are maintaining the entire kind of flow in a one room. The same way, if we are in a one corner, air conditioner is installed to maintain the ambient temperature in the room or in the ward. So at a one corner, air condition can be installed. So when air condition will run, it will throw the air like that, and exhaust will extract the air from one side, and the ambient temperature can be maintained inside the room or inside the ward. Coming to the intensive care unit, ISHRE suggests that relative humidity should be between 30 to 60%, and ICU can be positive, negative, or neutral pressure, but especially outside air should be minimum 2 air changes per hour, and recirculation of air minimum 6 air changes should be there. It required negative pressure minimum of 2.5 pascals or 0.01 inches in ICU rooms for infectious patients like coronavirus disease. Air handling unit should have at least 2 filters, MERV 7 and MERV 4. MERV stands for minimum efficiency rating volume. It is a kind of filter which are coming from MERV 1 to 20. How the number is increasing, the efficiency of filter is increasing. The exhaust to atmosphere will have to be with H13 or equivalent grade HEPA filter, or a plume exhaust into the atmosphere to a high level above the building. Converting general patient rooms or ICU into a COVID-19 patient areas. So these are the considerations pertaining to HVAC system. To convert an existing patient room or ICU into a COVID-19 patient area, it is first necessary to convert the room into a non-recirculatory system. That is 100% once thorough system. This can be achieved by blocking of the return air vents in the patient room. It is important to make sure that the air handling unit will have provision to receive adequate outdoor air supply. We have to also ensure the safe location of the AHU. It should be away from the parking area or for any contaminated area zone. An independent exhaust blower shall be provided to extract the room air and exhaust out into the atmosphere, preferably after suitable exhaust air treatment. So ICU to ensure minimum 12 air changes per hour with negative pressure of 2.5 pascals. Then how to treat the exhaust air from COVID-19 patient areas? There are different methods. So HEPA filtration is the most preferable method, which is recommended by the ISHRE. And the HEPA filter specification should be, it should have a minimum H3EN 1822-1 filter class or equivalent. Chemical disinfection can also be done by bubbling the exhaust air through a diffused air aerator tank holding a 1% sodium hypochlorite solution. We have to change on frequent basis to maintain its efficacy. Exhaust air can also be let off into the atmosphere through a high velocity upward plumb at a height of 3 meters above the tallest point of the building if HEPA filtration or chemical disinfection options are not chosen. Ultraviolet irradiations will only work if 254 nanometer wavelength irradiation with an exposure time of 15 minutes. Heating, ceramic heating is also now coming, and exposure time of 45 minutes at a temperature of 75 degrees Celsius can kill the all coronavirus. This is the emergency room and waiting areas. So generally, the same kind of that negative pressures should be maintained, 2 fresh air changes and minimum 12 air changes should be maintained. And air movement should be from clean to dirty areas. This is my second last slide, very important slide, that operating rooms with a positive pressures. So I would like to explain that this is the air handling unit. There are a 2 MERV 17 and MERV 14 filter has been installed. So air is coming out through this air handling unit and going through the inside the operation theater through the laminar flow. And through laminar flow, it is percolating through the OT table to the corner of the vent. And from the vent, it is going out again for recirculation to the AHUs. So this is the positive pressure. Then there is a airlock, one area, which is having a negative pressure. And outside general area, again, it is a positive pressure. So from the operation theater, air is moving towards the negative pressure. And from negative pressure, one exhaust is going out through the HEPA filter. So that HEPA filter is cleaning the contaminated air before discarding into the environment. So humidity should be maintained 20 to 60%. NABH recommends that 55% humidity should be maintained. That is ideal inside the operation theater. Velocity should be maintained 25 to 35 feet per minute. Temperature 21 degrees Celsius plus minus 3 degrees Celsius. Although in joint replacement surgery operation theaters, temperature can be maintained little lower. 2.5 Pascal positive pressure to be maintained, and minimum 20 air changes should be maintained with component at 4 fresh air components. So this is the model with the positive pressure operating room with use of HVAC and laminar flow AHU. This is the highly recommended model. This is my last slide of this my presentation, operating room with the negative pressure. So again, the same model, air handling units. So 2 MERV 7 and MERV 14 filter has been installed. Air is coming out inside the operation theater through laminar flow where HEPA filter has been installed, going in the operation theater with a negative pressure and then coming out And left hand side, there is a clean corridor. Outside of the operation theater, there is a clean corridor. It is also having a kind of more pressure than the operation theater. So that pressure is coming inside and going out through the HEPA filter exhaust system. So we have to maintain 2.5 Pascal negative pressure inside the negative pressure operating room. Only one limitation is there for this model, that due to the infiltration of the outside air into the operation room, the air quality inside the operation room could be compromised, because a lot of other aerobans come inside and they can harm to the patient as well as to the healthcare providers. So like that, we can create a negative pressures operating room. So although I have only this much of time, so thank you so much for your kind attention and giving opportunity to me to talk to me. I would also like to tell that recently during the lockdown, I have written a book, Airborne Infection Control Guide to Planning and Designing of Hospitals. It is available on Amazon and Kindle. Recently, this book has been launched by the Union Health Minister of Government of India, Mr. Ashwani Kumar Dubey. And whatever the royalty is coming, that is directly going to the Prime Minister Relief Fund for helping the COVID-19 patient. So thank you so much for your patience.
Thank you so much, Dr. Parvez. It was very nice presentation, and I request Dr. MSR sir to give comments on this presentation.
It's a wonderful presentation, very unique, and he has a lot of experience in handling this. Ophthalmology is a surgery where, unlike the isolation wards or where AHU care is being given, it was discussed enough. We don't really have to look for a native pressure operation theater. And as he rightly mentioned, the possibility of the air coming into the operation theater from surrounding, especially because the doors cannot be airlocked, airtight airlocking is not possible. So we have discussed this, we have decided to reduce the amount of positive pressure. Where there is 3, 4, 5, 10 positive pressure difference between the inside and outside, we have reduced to 2 to 3, so that the amount of air exchange is increased and fresh air intake is also increased in the AHUs. So the other thing is there's a lot of budget needed for structural changes. So we were also advised ultra HEPA filters, and then our tonnage has to be increased. These are, we already have a set of parameters, set of equipment in the operation theater. If you're creating a new one, that's all right. But if you are modifying it, then you'll have to titrate in such a way that you are safe, but also you're not going to do drastic changes. Window air conditioners are out, but there are, I think if we can give suggestions to a lot of OTs have split air conditioners. If we can specifically answer a few questions as to how we can increase the safety of split conditioner use in operation theaters, it will serve a lot of people. One is split air conditioners not cleaned properly inside. There are a lot of areas inside the AC indoor unit where you cannot reach and clean them. If we can give some guidelines as to how to reach them, I know exactly because we were running it about a year ago. We were running with not with window, but split air conditioner, but we had developed a technique of doing it. The other thing is the inlet of split air conditioner. You can put in a small 11 watt UV light there. So the air that goes inside also gets clean. And you can put an UV light inside the indoor unit of split air conditioners so that fungus will not grow in the tray and on the fins of the rotary fan. So these two inputs, Dr. Parvez Ahmed can give this. Otherwise, I think every OT, if it was safe before COVID area, with little modifications, it can continue to be safe, not only to the patients, but also to the staff. It is not the structure that's uniquely important. It is the function, what staff do, what staff understand, what staff behave. All these are equally important when you compare to the structures. This is my humble submission.
Thank you so much, sir, for very, very practical suggestions. Speaker, I request Dr. Amish to introduce our next speaker.
It is my pleasure to introduce to you Dr. Chandrasekhar. He is NABH coordinator at Arvind Eye Hospital, Coimbatore, and NABH assessor also. Has been chief instructor for hospital infection control programs at national and state level. The part of AIOS and Tamil Nadu Ophthalmic Association team for developing cataract guidelines during COVID-19 times. The task force member for a subgroup for International Agency for Prevention of Blindness in COVID-19 times, is instrumental in getting QCI's workplace assessment for safety and hygiene for COVID-19 implemented at Arvind, Coimbatore, and assessed as the first hospital in the country. Welcome, Dr. Chandrasekhar.
Thank you very much, sir, for the introduction. Respected speakers, moderators, and panelists, greetings to you all and all those members who have logged in into YouTube and Facebook. At the outset, I'd like to thank Dr. Uday and the team for giving me an opportunity to be part of this wonderful webinar. My topic is going to be on compliance of personal protective equipment and the choice of right PPE. So before this COVID-19, we have been concentrating mainly on endophthalmitis in a surgery patient to prevent. That has been the past and the current scenario. With COVID-19, it is going to be protecting also from COVID-19, the employees, patients, attenders, and whoever the visitor is going to come in. The SARS-CoV-2 is taking on the world at a very fast pace. Various countries are in various parts of the world and are at different phases. We are right on top with the second place with almost 90,000, 95,000 cases a day. But if you look at the total number of cases per million, we are very low. That is because of the huge population within the country, except that China has a different protocol and different numbers altogether. But what does that mean? Are we at the beginning of the end? Or the end of the beginning or beginning of the end? I think as far as India is concerned, we are still not even anywhere near the peak. We are still seeing a lot. So all these protocols that has been advised, hand hygiene, personal protective equipment, and the space distancing, physical distancing or social distancing will be there for a long time to stay, and most of them may continue forever because we will not be getting rid of Corona. We will be coming out of the pandemic, which was announced 6 months back. For any infection control, there are 5 levels. One is removing the virus. There is no treatment. We cannot permanently 100% remove at this point in time. Substituting with vaccine, we do not know how far we are away from. Engineering controls is, isolating people, keeping them away, various infrastructural changes. Administrative controls, how you post them, how many hours they work, and so on. And the least effective of all these controls is the personal protective equipment. It is surprisingly the least protective, but the most followed across the world. Why is it least effective? Because it is not being followed properly. That is the most important thing we must understand. Everybody knows the use, but they don't follow it. And even when we follow it 100%, it is not totally 100% protective. There are many, many personal protective equipment available. And what we need to know in this, at the end of this talk would be why to use a PPE, what is the PPE to choose, and how to do it. The whole compliance will depend on the teaching and training of the staff to make sure. All along, even before the Christ era and to now till the Spanish flu, there have been many pandemics and there are many lessons that have been learned. Even in the 14th century, the Black Death taught us a big lesson. This was the earliest PPE the plague doctor used to wear with a complete defined cloth and a beak-like hat and face cover, which contained the antidotes, and the perfume to prevent the death of smell of the death. And he was carrying a stick to move the patient around without contact. Surprisingly, Goodyear's finding the vulcanized rubber has been used to make the surgical gloves. And then this was the earliest surgical mask, which was nothing but a glorified cloth, which was made of cotton gauze. And this bubble like N95 mask got its inspiration from the person who did model designing, Sarah Little Turnbull, from which they got the idea of a N95. The 3M got the idea. There have been changing facts and guidelines, as it has been told so many times, and PPE is no exception. Initially, CDC said no mask. Then they said mask. They said only N95 will protect. Then they said limited reuse and recycling of N95, and then so on and so on. Some new facts are coming which are not confirmed that N95 is also not totally protective. That is how it is. These facts will tell us, though the size of the SARS-CoV-2 is less than 0.2 micron, but actually what spreads most of the time is a droplet, which is about 5 to 10 micron, or a droplet nuclei, which will be less than a 5 micron size. This we know it spreads through the mouth and the nose mainly, and sometimes very rarely through the eyes. But the most important here is at the speed at which it spreads, even talking can spread. Now, some of the prevalence studies going on show that there is 30 to 35% of seroprevalence. That means they have IgG in them, that they have been exposed in spite of proper PPE. What does it mean? Does it mean that we don't have to have a PPE? No. These PPE prevent us from getting a high viral load, reduces the speed of this virus coming out. And if two people are there and both of them are wearing a mask, it is going to protect them almost 95 to 97%. That is what we understand. And this stealth-like transmission of virus is something we must understand. It is invisible, rapid, and can spread in any particular direction. This is something more important. The contact duration between a patient or a person who's got a corona and another person will be at least 10 minutes for them to take, unless the person coughs or sneezes. This is very important to understand. And even when you're going to examine in a slit lamp or something, after examination, make them sit at least a meter distance away and do the talking. So these personal protective equipment are very important. The most important part is to assess what is the risk for the employee in the hospital. It depends on the patient they are dealing with. Most of the eye hospitals, standalone eye hospitals, are non-COVID hospitals. And the distance at which they are going to talk to them or have contact with them, duration, and the job of the patient. The Ministry of Health and Family Welfare has given a couple of guidelines. It has modified, giving proper guidelines to what to use. Eye, ENT, and dental doctors are under close purpose for examination, so they need to wear a N95, the goggle, and the gloves. Ward and individuals, you need only a triple layer mask and a gloves to touch the patient. Operation theater, even a triple layer mask, face shield, and a sterile latex gloves is good. If it is going to be an aerosol generating procedure, like we are doing a DCR or a GA for an anesthetist, they need to wear more complete PPE and so on. Even for a laboratory, CSSD, these guidelines are covered. Even they advise face cover for people who do not come into contact with the patients. So all these guidelines are given by so basically you can divide them. Those people who never come into contact, like only the office people, are no risk. Low risks, they communicate with the patient. It can be a security person, but we can maintain a 1 to 2 meter distance. And a moderate risk, they come in contact with the patient, no aerosol generating procedure for a shorter duration. They need a respirator, glove, face shield, and goggles, or a properly worn shield. The high risk could be those patients who are touched, who are for a longer duration, where there is aerosol generating procedure. They may need a gown or a complete PPE. So these are all basically the combinations, triple layer and mask in the front areas, and a shield is always an additive effect. And moderate risk areas, we need a N95, gloves, and a shield. And in doctor's chamber, as I already said, you need a N95, gloves, a goggle, or a face shield. I know it is going to be difficult to look at the slit lamp with a goggle, not possible with a face shield. Emergency and red eye clinics have to be taken as high risk, and N95 gloves and a full PPE would be better to use it. As I said, in the operation theater, a surgical team will be only under a moderate risk unless there is a GA or a DCR procedure where you need a complete PPE and N95. So other categories where there is no contact, they can have a cloth cover, which is the face cover. It can be in admin, kitchen, finances, and patient and attendants. Most of them come with facial covers. You need to develop a small document saying the rational use. There are two things to be done. What PPE is to be used for which category should be decided by the management, and the people who are involved in the task force or the people who train should teach them what is the PPE, why is it necessary, how to don and off, and especially in between periods, how to handle with that. That is where there is a lot of breach in the PPE. So personal protective equipment, first and most important thing is to remove all the jewelry, watch, cell phones and flowers. And then most important, now previously for preventing endophthalmitis, we were giving a lot of importance for donning. But now doffing has more importance because when we remove all the PPE, we assume if there had been a person with the coronavirus, all the external surfaces which we have been using as a PPE will be having definitely viruses. So it has been found out doffing properly, improperly can lead to contamination and infection. So first step in donning and the last step of doffing would be a proper hand wash. It has been proven that these 8 steps followed by WHO, the European norms, are definitely going to cover every part of the hand 100% to make sure it is a clean hands before you do any donning and at the end of doffing. This is very important. We can say the masks are the mother of all PPE. Definitely they are the mainstay. We have two groups. One is the surgical mask, the 3-ply mask, and the respirators, which the N95 is the supposed to be most important. There are different types of classification. The European norms say FFP, filtering face pieces, and then you have the N95s and so on. Now the surgical 3-ply mask has got 3 layers, the non-woven, filtering, and the soft layer. It should be always a waterfall pleat. The fold should face downwards. The darker side should be outside. That is the correct way to put a surgical 3-ply mask. The respirator has got 5 layers, not going into all the things, but this is absolutely fantastic, and it can almost 95 means 95% of the times 0.3 micron of the particles can be filtered. But the most important here is it should be fit properly and the seal should be good. This is the European and the American norms. The respirator can filter 0.3 microns, and you have the Chinese norms and the European norms as well. Now, for example, you have to find out whether you're wearing the correct N95. If you look at that, each N95 from 3M will have a number. You can go into the NIOSH or the CDC website and find out if these numbers match. This cannot be duplicated. If these are matching, that means you're wearing the original N95s. These N95 used to cost 600, 700, and now they are giving at a cost of 36 and 37, sub 40 rupees. So donning an N95 is very good and important to make sure that you do it the proper way. You better to have no facial air because it can cause compromise on the stability of the N95 protection. You hold it the right way with your hand, left hand. Then after you hold it, first you have to put the upper string, not the lower string. Then the next, the lower string is taken above the upper string and put behind the head. So ultimately, after fixing, the seal test has to, we don't do a fit test because you need a kit which costs much more costlier than the N95. So you just hold on the mask like this, breathe in and breathe out, and see if you can feel the N95 going in and coming out. That will make sure your fit is good. Actually, there are different sizes, but because of this crisis, we don't get very many sizes now. This is a properly owned N95. Coming to the doffing aspect, removing the lower string first is the first thing to be done. Then we remove the upper string. You may ask why. I'll come to that. While removing the lower string, it is ideal to bend forward, either whether it is a surgical mask or a N95, because we do not want the outer surface of the mask to touch the body or the dress. So that is supposed to contain the virus if at all any. So you should handle it carefully without touching that. So people with breathing difficulty, many of these masks are available with exhalation valves. It is absolutely banned because they can exhale the viruses. So you don't even advise them to have. If they have one, ask them to remove it and you give a mask and ask them to wear. There are some reusable, washable masks, and they can be used like a cloth mask, but even those masks with exhalation valves are not avoidable. These are advanced ones with HEPA, with positive pressure oxygenation, with UV filter and so on, which is absolutely costly and no need to do at this point of time. The CDC says it is only a single-use respirator. But what happens? This is a crisis. So CDC has given extended use from 4 to 6 hours. It can be 6 to 8 hours and limited reuse capacity. It can be minimized to individuals to make them use only for people, not even the entire hospital. For whenever it is soiled or contaminated, it should be thrown off. Proper donning and doffing should be followed. Now, decontamination, many methods are available: ultraviolet, germicidal irradiation, hydrogen peroxide vapor liquid, and mostly the drying method. We have other methods like microwave oven and so on. This is the ultraviolet. You can easily make these things. You just have to put them, just give them 2 of this N95 masks or respirators. It can be used on alternate days, very short period with 254 nanometer frequency. It can be radiated, can be used up to 10 to 15 times. This is very, very good, and it can be used. The other method, which AIIMS was one of the first institutions to follow, give 4 masks, number them 1, 2, 3, 4. On day 1, 1 mask is worn, 2, 3, and second, third, and fourth day it is dried up. Then day 2, day 3, and the first mask comes back on day 5, and this can be repeated for 5 cycles for 20 days. These are dried up in paper bags, allowed to dry without any humidity inside. This is a fantastic method, and that is good. Surgical 3-layer mask, the same way. You have to tie the upper string first, then the lower string. This is also equally important to follow. It should go on top the first tie and then the lower tie, and then make sure it is fixed properly. After that, removing again, you follow the same principle of removing the lower tie first and then the upper tie. It goes into the yellow color bin. Surgical 3-layer masks are very effective, and like what Dr. Ravindra said, if you can tape them on all sides, it is as good as an N95, if not better. There have been quite a few studies which have proven a properly owned 3-layer surgical mask is as good as N95. Though there are not much of people in COVID-19 hospitals, staff in COVID-19 wards do use N95, but there are many restrictions on it. Surgical 3-layer mask is as good a 3-layer as a N95. So the cloth mask for certain people, they also should follow the same, because once they wear these masks, the outer surface of the mask should never be touched. Otherwise, you will be reinfecting. So remove it, and then this is something which we see commonly, whether it is a 3-layer mask as this, absolutely useless, and it is as bad as done. You have to throw that mask away. Otherwise, there is no use. The next comes.
Please sum up.
Yes, sir. A face shield and the goggles, you hold it with a frame and then use it. The gloves are worn. Everybody knows you don't touch the outside when you wear it, and you touch the outside only when you remove, so that the own gloves is also infected. When you remove, you have to be very careful and remove it like this. And the other glove, you put your hand inside and remove. So this complete PPE, very minimal role is there across the institution to make sure that we have this. These HIV kits are like PPE. Other things are not being used now. The OPD donning and doffing will depend on what are the PPE you are going to choose. You know, there is a particular way. You start off with the scrub suit, and then go on to finally wear the gloves, the second glove, and go on. Same way you come out with the removing the gown, the shoes, the gloves. Then you can have 2 masks. Finally, you remove the N95 and have a wash. That is important. Before a face shield and a mask is worn, after a face shield is worn, you can see, you know, after the goggle and the mask is removed, entire face is with virus. So after removal, you have to have a face wash. After OT, better to have a complete bath before you leave. This is the amount of PPE we use monthly in the world. So we need to remember, we have to be very careful in disposing them, and the masks are better destroyed. They are cut and then thrown so that it is not being misused. So this is something, pandemics may come and go, medical masks are eternal. I would like to thank the organizers for giving me this wonderful opportunity. Thank you so much. Wonderful being with you all. Thank you so much, sir.
Thank you, sir. And I invite Dr. Shashi Kumar, sir, for comments.
Thank you, Dr. Chandrasekhar. That is most exhaustive talk ever. And you don't have anything else to say about this PPE mask and the gowns. But one thing I would like to comment is that N95 mask is very good. But the thing is that it is very difficult to wear for a long time. See, people who are having migraine tendency, it is very difficult, because if you can have a properly fit N95 mask, and if you can breathe comfortably, then it is not an N95 mask. Because it is very difficult to breathe with the N95 mask on. So I think the surgical 3-ply surgical mask, which is taped all around, is a very good option. And regarding the PPE also, I think other than the surgery part, it has got very limited role in ophthalmology. The rest we can take up in the discussion because we have already overshot time. Over to Dr. Uday.
Thank you so much, sir. And we move on to the next talk. And it is my pleasure and privilege to introduce a good friend of mine, Dr. Jagdeep Kakadia. Completed his MS from Vadodara Medical College in '89. He is in solo practice since 1990. Has done more than 63,000 cataracts, more than 8,000 LASIK procedures, and more than 250 cataplasties. He has invented OmniGlow, a stereo coaxial illumination device much cheaper than the commercial ones available in the market. He is a pioneer designer of ophthalmic examination chair unit. He has done clinical research on RHO kinase inhibitor as eye drops. He has developed his own homemade excimer laser. He owns an IOL manufacturing company. Actually, he is an innovator. He has innovated some instruments also. And he is, in addition to all this, a well-known popular writer in Gujarati literature with 4 bestseller books. We look forward to listening to him from on this which is something totally different we have never thought of. He says he has never used any PPE even while dealing with the patients. So let's listen to him. Over to Dr. Jagdeep Kakadia.
Thank you. Thank you, Dr. Uday. I'm so happy that you invited me for this webinar. Is my screen visible?
Yes.
Yeah. Okay, fine. Uday, in front of these national stalwarts and international stalwarts, I would look like a dabang or a maverick, but let me present the 5 Brahmastra which I have found during my research in last 7 or 8 months. How can we fight against this coronavirus? I've done a significant amount of in vitro study at various laboratories, including the National Institute of Virology, on this virus. And these are the 5 things which we have found extraordinarily well working against this virus. That is methylene blue, tablet ivermectin, UVA and UVC lights, hydrogen peroxide of medical and food grade to be taken in vivo, and medical grade ozone to be also taken in vivo to protect ourselves. We have treated at least 50 patients of COVID with this combination, ivermectin 12 milligrams, Zincovit, and and the doxycycline 100 milligram given BID for 3 days. And this therapy works so very well that nowadays we are not afraid of the virus at all. And we put all our patients on ivermectin 12 milligram 1 day before we proceed for the surgery, and all our staff take tablet ivermectin 12 milligram once or twice in a week as a prophylaxis. And this really works extremely well. This is my own experience, and not only mine, but experience of many researcher groups. 33 randomized control studies have been done all over the world. And bypassing the ICMR's initial guideline. Of course, now ICMR has also started considering ivermectin for the treatment as well as for prophylaxis, which is far superior, which is found far superior than hydroxychloroquine. And one of the wisest ruler of our country, Yogi Adityanath, the Chief Minister of Uttar Pradesh, has already implemented in the UP government ivermectin as the prophylaxis for prime context, also as prophylaxis for healthcare workers and for the treatment of COVID positive. So ivermectin is a drug which is absolutely worth considering, very positively, and it really gives very, very good results. This is my personal experience of treating more than 53 COVID patients. Second thing is UV light. So UV light of Philips or Osram which is 4 feet in length and 36 watt output, will cover an area of 10 feet by 10 feet. So 10 square feet or 1000 cubic feet area is well covered by UV light, and we have done enough experimentation to find out that in less than 14 seconds in this much area, one tube light will inactivate the COVID virus. Of course, for killing the bacteria and for fungus, we need about 40 minutes exposure in the operation theater, but in the OPD and in other areas, we are not much concerned about the bacteria and the fungus except the theater. So in our hospital, we have UV lights installed everywhere, not from now, but from 2009 when Bhavnagar was hit very badly with swine flu epidemic. And since those days, we have been using UV light in our hospital. Every room, everywhere there is UV light in the OPD, in the refraction room. Almost every room is having UVC, even in the stairs, in the hallways, in the passages, even in the lift, and on the lift buttons, and even in the toilets. We have found that UV light inhalation, taking UV light directly into the throat, kills the infection, not only COVID infection, but all kind of viruses and all kind of bacteria within a minute or so. So my staff has made it a habit of inhaling the UV light, taking UV light and inhaling the ozone every day before they go home. And we have also installed UV light as an upper room air sterilizer above the split air conditioning here, so that all the air which is sucked into the AC and which comes out has at least this virus disinfected. Our hospital in the evening looks so bluish, or every room looks so bluish off and on, that Akshardeep Eye Hospital, now many patients in Bhavnagar, they call it Akshardeep UV Hospital. And not only hospital, even my home, we have installed so many UV lights in every room, especially the drawing rooms and the kitchen, where the staff and the assistants and the guests keep coming and going. So UV light keeps on coming on and off. And with all these UV lights, we have got a special timer designed. So every 20 minutes, every 15 to 20 minutes, the UV light is on for 30 seconds and then it goes off. And in the night, when nobody is there in the room, the UV light will be on for about an hour to kill all the fungus. And after installing this UV light, we find that there is no fungus which occurs in the corners of the wall in the house and in the hospital. So UV light is something which is really to be embraced open-mindedly and open-heartedly without the fear of carcinogenicity, because UVC light does not induce any carcinogenicity. Now about methylene blue. Methylene blue we have found to be very potent killer for this virus. And of course, this was first used by Dr. Paul Ehrlich in 1881 as intravenous injection for killing the falciparum, for killing the Plasmodium falciparum of the malaria in those days in Germany, and for which he was awarded Nobel Prize in 1908. So methylene blue has a history of almost 135 years of use in medical. And till the sulfonamides and penicillins came, methylene blue was the only drug of choice for treating sepsis and treating so many infections. And I learned a lot from Dr. Deepak Golwalkar, who is a very well-known pulmonologist here in Bhavnagar. Since 42 years, he is practicing in Bhavnagar. And he has treated more than 1,200 patients of swine flu with methylene blue from 2009 to 2014. And I have seen him treating over 650 patients by now of COVID-19 with methylene blue, just methylene blue and nothing else. And after learning from him, I believe he deserves a Nobel Prize or he deserves a Padma Vibhushan. After learning from him about methylene blue in depth, And we know that we used to use methylene blue when we were in college. And even today, methylene blue is being used as an antiviral to prevent infection spreading from one species of the fish to other species in the aquarium all over the world, the professional or the domestic or home aquarium. So I learned so much from Dr. Golwalkar about methylene blue, and since my brother is a COVID specialist and he owns an ICU of 20 bed in Surat and in Bhavnagar, we started using methylene blue for the treatment of COVID. And there are n number of studies have been done, and there are so many papers which have come up that methylene blue kills not only all types of RNA virus, not only coronavirus, but also dengue and chikungunya viruses in 2 minutes to 3 minutes. It kills almost all lipid envelope viruses like HIV, herpes, toga virus, and hepatitis C virus also, West Nile virus also. And Mount Sinai Hospital in New York is also using methylene blue for COVID-19, and this is their report that on hospital day 6, one patient received 1 milligram per kilogram of methylene blue intravenous. However, he demonstrated minimal response, so they gave on hospital day 7 the second dose of 1 milligram per kilogram of body weight, and on day 3 they gave 2 milligram per kilogram of body weight intravenous methylene blue, and then the patient gradually improved and he was out. So let us explore how methylene blue works in COVID-19 and why. This paper actually came up from CDC Beijing, which is a military-controlled hospital in China. And this paper was published in 2005. And it has clearly shown that 5 micromole per liter of methylene blue inactivates 6.5 log of this virus in 3 minutes. Now, 6.5 log means 99.99995% of viruses were destroyed in 3 minutes when the concentration of 5 micromole per liter of methylene blue was given. And then this paper came up on 17th of March from Hangzhou University in China, which also states the same, and I'm associated with this university as a visiting professor where I go for frequently for lectures and for surgical training of their residents, and also conducting camps in rural China. So I know their work. Now, methylene blue has number of mechanisms of actions against this virus. Number 1, it kills viruses in 3 to 4 minutes. It makes cellular cytoplasm and extracellular fluid into an alkaline medium, and in alkaline medium this virus has an inhibitory effect of replication, so it does not allow the replication. It is the and the only chemical treatment of methemoglobinemia which is induced by this virus. So methylene blue reverses the methemoglobinemia, and once you give 1 intravenous injection and the SpO2 increases from 85 to 100 in 20 minutes or 30 minutes because of the reversal of methemoglobinemia. And methylene blue also, upon chemical contact, instantly inactivates interleukin 6 and TNF alpha. It also stops the secretion of IL-1 beta and IL-18. So all the cytokines are inactivated or prevented from being secreted. So methylene blue has a very great role in calming down or suppressing the cytokine or preventing the cytokine storm if given in early stage. It also prevents intravascular coagulation by blocking thrombin, fibrinogen being converted into fibrin by thrombin pathway. So this also helps in preventing the intravascular coagulation, which happens in post-COVID recovery phase. And it also has a role of prevention of peripheral vasodilation and hypotonic shock, because methylene blue inactivates nitric acid and cyclic GMP. These are the 2 chemicals which leads to peripheral vasodilation, as a result of which in septicemia the blood pressure falls and the multi-organ failure starts happening because of the vicious cycle. And the patient goes into an irreversible one-way street. But methylene blue prevents that by blocking nitric acid and cyclic GMP. So what we have found in our use of methylene blue in 53 patients in the last 2.5 months is that if used well in time, 200 rupees 2 injection is better than remdesivir 11 dose, tocilizumab 2 dose, favipiravir 100 tablets, heparin, and all other supportive therapies. So the 400 rupees of methylene blue is more effective than 1.5 lakh rupees worth of medication of the above drug combo. And the best action of methylene blue is it prevents fibrosis of the lung. So in post-COVID patients, we give methylene blue nebulization for 2 to 3 months, advised for 2 to 3 months. And this is our experience of treating swine flu and multi-drug resistant tuberculosis inducing interstitial lung fibrosis. And you can, if you do the bronchoscopy, we know and we can see that the hyaline membrane, which is being formed by this virus, is so tough to be dissolved that the mucin-like secretion, which gets matured in 3 to 4 days and gets expectorated by the patient in a normal pneumonia, does not happen here. And this membrane eventually leads to the fibrosis of the lung. And when we do...
Sir, please sum up. We are running out of time.
Right. Okay, fine. So I'll stop here and maybe we can then discuss in the questions and answers because it's a very long topic. Thank you very much, and I'll stop sharing my slides here. Right.
Sorry for cutting you short, sir. I know it was very interesting and a lot of learning for all of us, but since we have overshooted the time of 4 to 6, we are already at 6:15. May I request Dr. Savitri Sharma, madam, for a few comments on this presentation.
I am completely zapped. I don't know how methylene blue is such a wonder drug. Seems to be from the description Dr. Jagdeep gave. How come, my question is, why is it not more popular than other antivirals, remdesivir, and we are talking about? Why methylene blue is not coming into the popularity?
Maybe it is gradually, ma'am, it is gradually coming up. I know at least 30 COVID centers in India who have now switched over to methylene blue as the prime or the first line of therapy. And in a mild to moderate patient, if we give one methylene blue injection on day 1 when the patient arrives, after ruling out the G6PD deficiency, it kills all the viruses in less than 4 minutes and it kills the cytokine storm, and in 1 day the patient is cured.
It seems to be the answer for everything that is happening.
Absolutely. It seems to be the answer to prevent dengue, to prevent chikungunya, and to prevent falciparum malaria, which is at least in Gujarat, because of very heavy rain, we are going to see that epidemic coming on in 20-25 days from now. So it's really working so well.
Are you recommending it for prevention in normal people?
Yeah, those were my next slides. That taking 2 milligrams of methylene blue, that is 0.2 ml in the morning and 0.2 ml in the evening. Orally, sublingually or orally, or you can drink 2 ml of methylene blue in a lime juice, and it prevents you from all the kind of viral infections. Number 1. Number 2, I have treated several patients who had chronic tonsillitis who were on various antibiotics for last 6 to 7 months. In 1 day, their tonsillitis was gone. And the dental pain, the gingivitis, the dental caries, everything goes. Even the commensals are killed.
These are all your clinical observations or people have observed, but where is the research to support this?
Oh, there are. You just go to Google and just type methylene blue against dengue virus, methylene blue against chikungunya virus, methylene blue against West Nile virus. You will find all the papers. Actually, this lecture contains 170 slides, and I have shown every paper.
You had only 8
every
minutes.
Institute. I actually need an entire webinar to me for this.
Depend by, please note. Depend by.
It was an eye-opener actually. It was an eye-opener.
Point noted, sir. We will definitely take it up.
My only concern is...
Thank you.
I hope methylene blue really comes to the rescue of the people.
Yeah.
Yes, ma'am. You give me 1 hour's time in the next webinar, and I'll show you every research which has been done on methylene blue, not just by me, but from the world over.
No, I am going to request to Namrata Sharma to give 1 hour at AIS level, so that and book one slot in a national TV channel, so that all the politicians here.
Yeah.
All the healthcare workers.
Ma'am, we have treated one mother who is 94 years, mother of the most popular leader of the country. She was admitted in BJ Medical College. She was almost on the verge of collapse and nothing was working, and she was saved only and only thanks to methylene blue. I cannot name her on a public platform, but so the top brass in BJP, they know. SP Balasubramaniam, who is waiting for the lung transplant, his family has also considered, with the mediation from Dr. M.S. Ravindran, who is a very close friend of SP Balasubramaniam, to take methylene blue as inhalation to reverse the lung fibrosis. And if Dr. Uday permits me 2 or 3 slides to be shown how much the lung fibrosis gets reversed with methylene blue, I would like to show those 2 or 3 X-rays. So that the post-COVID recovery for all of us is also becoming a problem, that we are going to develop severe lung fibrosis after 3 months or 4 months. Even that is reversed by methylene blue. So methylene blue is something working like a miracle drug, like working like a blue magic.
Yeah, it sounds like magic. But let me also go to the other part for discussing your presentation about the UV light. I appreciate that the various parts of your hospital you have put that, and it is definitely a microbicidal effect of the UV light, which is seen everywhere. It includes viruses and other organisms. But what actually bothered me a bit in your presentation is exposing the patients to open their mouth and inhale UV light. Where is the scientific proof for that? Do you have something to really back up that one can inhale UV light? It is supposed to be a surface disinfectant. Only on a surface it will kill organisms. How will it go inside the mouth? And then are we not doing injustice to the people, asking them to stand in front of the UV light?
That's why I said in the beginning of my lecture that I might sound dabang or maverick. Now, I would like to clarify 2 points on this. If you go to NIOSH or if you go to the websites of the upper level, the highest level of UV tolerance dose.
That we heard. Excuse me, there is no need to repeat that. We heard UVC is safe. Now, how sure are you that those bulbs which we are buying in the market, the tube light, I think you said 36 watts or something, it is only emitting UVC? How sure can we be?
Oh, ma'am, you can measure it with a UV meter. I have all the meters. I have the wavelength meters, I have the intensity meters, and we can measure. And in fact, I have made one device which is known as Coronash, and that device has become so popular all over Gujarat and all over ophthalmic circles that I have at least made and displayed more than 3,000 Coronash devices. Which shines UV light for 40 seconds in your nose and in your throat, and it kills all the viruses, not only viruses, but all the organisms
present. In the throat and in the mouth, did you check the viruses which were killed, or you assume that they are killed? How do we check? How do we check the mouth?
Yes. You do the RT-PCR after, you do the RT-PCR today morning, it comes positive, you take UV light and do the RT-PCR after a day and it comes negative.
You have done that?
Yes.
You published that?
Not published. We have just compiled and finished that study. Our study is registered with CTRI, and study has been done at Bhavnagar Medical College.
Okay, thank
so
you. I would just like to chip in here. I think there are many questions and many feedbacks coming from all over India. where they have shared that they would like to have a dedicated webinar which Dr. Jagdeep was referring.
Yes.
So on behalf of the thought of Dr. Lalit Verma, at IPCA, we will be grateful, sir, if we can give one exclusive dedicated webinar which can be showcased to the entire ophthalmic fraternity for the wonderful work that you are referring to.
Yes.
Sure.
That's required.
That's a nice idea, Deepan.
So we will be willing to support it, sir. And on behalf of AOS and Dr. Jagdeep, I think it's a wonderful thing that has come out, and many doctors have been commenting on it on the chat. So we will be very happy to support this initiative.
Okay, very good, very good. All right.
Okay, since time is running out, there won't be time left for even for question answer. So let us just finish off with the small presentation that is left.
Dr. Uday, will you please allow me to show the slide, just 2 slides. See, this is the patient of multi-drug resistant tuberculosis, miliary tuberculosis, having the left lung completely lost and the right lung partially lost. And with methylene blue inhalation, in about 12 to 13 months, his lungs got completely cleared. And this is another patient of Dr. Deepak Golwalkar, who had massive interstitial fibrosis all over the lung because of the severe miliary tuberculosis. And with methylene blue inhalation, over a period of 18 months, his lungs came completely to be normal. So methylene blue is something which really deserves a complete attention and a full-scale webinar just on that one topic.
What is the dose of inhalation, Dr. Kakadia?
Yeah, that's 0.7 ml. Methylene blue comes as an injection. You take 0.7 ml and add 7 ml of water to make it enough into the inhaler's cup, and then you inhale it twice in a day, and that reverses the pulmonary fibrosis. I know one Dr. Subhash Telang, who is a very well-known cardiologist from Bhavnagar. He suffered COVID and he had started having interstitial lung disease after COVID, and with methylene blue inhalation.
I too have quite a few patients, so I can suggest them.
Oh, yes, yes, sir. It
Thank you
works
very
like
much.
magic, and this we have experienced not now, but from the swine flu epidemic. From 2008 to 2014, we have treated more than 1,200 patients with methylene blue inhalations.
Thank you very much, Dr.
Yes,
Kakadia. It was excellent, and we move on to our last presentation. It is by our own Dr. Uday Gajiwala. We have been listening to him since the starting of this webinar. He is MS Ophthalmology from M&J Institute of Ophthalmology. He was my senior. I'm very lucky to have him as my senior. At present, he is a superintendent at the Tejas Eye Hospital, which is run by the Divya Jyoti Trust in one of the most remotest places. It's a Adivasi area, rural, I would say Adivasi area of South Gujarat. He has deep interest in infection control practices. We started that since 2004, when we came to know that we were not knowing anything about infection control, and he has reached to such heights in the science of infection control practices. He is rooted into community ophthalmology. He has got few publications in international peer-reviewed journals. He is authored a manual of infection prevention and is involved in conducting many epidemiological studies. I would like to welcome Dr. Uday Gajiwala and request him to go forward with his presentation. Dr. Uday.
Okay, is my screen visible?
No, your screen is not visible. Depend by your screen is there. So,
Sir, you need to share your screen. I think.
Yeah.
Okay.
Uday, please share your screen.
Yeah. It's not going to be a long presentation, don't worry. I will just tell you a couple of things which will be thought provoking. So I just wanted to think about what is new as far as prevention of infection is concerned, particularly in this post-COVID era. So corona also is a viral infection. We have changed our OPD practices to start using mask, hand sanitization and social distancing. Inside the OT, now we are saying only one table, only one patient at a time, re-scrubbing after each surgery, minimum staff inside the OT. So my question, I'm thinking openly, has the science of infection control changed in any way because of the corona pandemic? This is a viral infection. Our infection control practices should be enough. Why these changes? As mentioned previously also, it's because of the fear of mortality. Infections were occurring even before COVID-19, but they were not fatal. The virulence of coronavirus is high, although the virulence has gone down over a period of time. For stricter version of the protocol, initially before corona, we felt that the cost-benefit ratio was not favorable. But what about those unfortunate patients who develop endophthalmitis? When one patient loses vision due to endophthalmitis, is it not a fatality from ophthalmology point of view? I would like to remind ourselves what Sir John Wilson had said. People don't go blind by numbers, they go blind individually. We have to be dealing with them individually. Look at all the changes that we have implemented inside the OT. NMBH always suggested these things, and some of the institutions are practicing this already. So, is there anything new? Well, in my personal opinion, no, there is nothing new. The major difference is that the cost benefit ratio is not favorable for a very stringent infection control protocol. But then we have started following it due to corona. So what will happen once the pandemic is over? Well, we need to take a call. Can we afford the higher cost of a strict protocol? Well, it is definitely qualitatively a much better thing if we can follow the stricter version of the protocol. And I just would like to remind everybody that our target for post-op infection is 1 in 15,000. That is where the developed world has already reached. Why not in India? We have come a long way as far as ophthalmology practices are concerned in India. We are doing more than 7 million cataract surgeries every year. Let's look at reducing the rate of endophthalmitis in the country. Thank you. I just wanted to provoke thinking in the minds of the listeners, and that is why it was a very short presentation. With that, I end my presentation. Dr. Amish.
Yeah. Thank you, Dr. Uday. And I would like to request Dr. Deepshika to give her comments on this.
Yes, yes, sir. Dr. Gajiwala sir has rightly said, like, now after this corona, what the change we are going to do and what how we are going to control our this infection part as we are dealing endophthalmitis and treating. So that he has rightly said we have to follow all the these protocols with very cautiously, and maybe we have to change our lifestyle also. We have to live with this type of situations and how we have to protect. And what is in my mind, because of these situations and virus we cannot eliminate, we cannot isolate the people. So now maybe some procedures are going to become to deal with these situations, like telemedicine, artificial intelligence, ki maybe we are going to some home devices where the patient will examine patient themselves, and they can transport their data, as well as for research education and training programs. So in spite of these situations, we have to learn to live with these situations. This is my comment.
Madam, I would like to ask you one more question. That what
Yeah,
are the
please.
changes have you made in your OT protocol in this
Okay, so
era of COVID, and what is the key of protection to both the staff as well as the patient?
yes.
What do you
Uh,
think that it
yeah.
is a key
At,
point for protection?
yeah. At MGM, actually, we are NABH accredited. So already we are following all the standard protocols. But because of this COVID, we have made some changes on the basis of guidelines of Government of India, AIOS, and the state government. So what we made a changes in our hospital, we are using half capacity of our operation theaters. We have made the teams, so they are not coming daily. After that, we are focusing on training, their monitoring, and auditing, because in between usually the staff becomes a little bit reluctant. We are doing OR surveillance on daily basis, and we have a nodal officer which is consultant is in charge for operation theater, and he is reporting to the nodal officer about any incident if it is happening. So these changes, otherwise what the other people are following, that we have a operation theater, we have separate AHU, and we are doing microbiology surveillance also. For GA, we are taking all precautions which already has been discussed by the other speakers. So in that way, we have made little changes, but not infrastructure or other things. Second question which you have asked about the how to what is the key
Key
to prevent
for the
infection.
protection of our
Yeah.
staff as well as the patient.
Yeah. So already it is discussed in a detail. So I would say appropriate and adequate protection with using of the PPE kit. PPE kit means not the exact PPE kit, but it is like mask, gloves, gowns, whenever it is required, and less exposure or no exposure with virus in unprotected condition. So at this point, we can say mask is like a vaccine. Till the vaccine doesn't come, mask is going to reduce the load of the virus. So this is the key point. Otherwise, like in hospital, if we say, so we are segregating the clinical, non-clinical staff. So and there is a less movement, preventing the cross movements, as well as like teaching the staff for their self-assessment. Whenever they are feeling any symptoms, immediately they should report. We can isolate them immediately. So in that way, they will prevent the spread of the infection. For the patient part, we have to take proper history, their temperature, oxygen levels. So, and we have to educate the patients also. And of course, we have to make the social distancing. So these are the factors where we can protect our health care worker as well as the patients.
Dr. Savitri, madam.
Amish, Dr. Amish, we'll have to call it off at 6:45. We have 7 more minutes. You can go ahead and ask Madam one or two questions.
Yeah, we
Please,
want
please,
to
carry
take
on.
maximum advantage of
Yeah,
it.
yeah, please carry on.
So mask is the key, but I think that social distancing and hand sanitization, can you just throw some light on that? Because I think that is also very important. And I would like to ask you one more question, that what is the importance of rapid antigen test? Is it necessary, or is it effective, or
I'll give you the ground situation that we are having about the rapid antigen testing. We have a center in Bhubaneswar, LV Prasad Eye Institute, Bhubaneswar. They have started testing. They got the permission from ICMR. You need permission from ICMR to start testing because you have to feed the data in the ICMR portal. So they got the permission. They have started doing it for all GA cases, and as we discussed earlier, the type of patients who require this. And we have whenever a staff is having symptoms and suspected, those are the people who are being tested. And what they find is its sensitivity is very low. According to literature also, it is around 50 to 70% only sensitivity. So when it is positive, it is very specific. If it is positive, the patient is definitely having but if it is negative, when there are symptoms, you need to send the patient for RT-PCR. That is very important. You cannot take the test on face value. Could you hear me?
Yeah. Yeah, we are able to hear.
Are you able to hear me? There was
Yes,
some
madam.
internet problem.
No, we are able to hear you, madam.
Yeah, we are able to hear you.
What I said was, if the test is negative when patient is having symptoms, you need to send the patient for RT-PCR and cannot take the test on face value.
Yeah. So I think that it is only for screening.
You have time for the
and
other question you answered, mask.
Hand sanitization. And social
Take 1 minute to
distancing.
answer the second question also, madam.
I think all three are like Trishul. All three are required.
Equally.
We just cannot do without one of them. All three. All three. Absolute must, all three.
Thank you so much, madam. Dr. Amish, you can deliver a vote of thanks, because then Dipin Bhai also will have to say something. We just have enough time, 4 minutes.
At the end, I would like to thank each and everybody, all the speakers and the panelists, to join us and giving us excellent presentations, enlightening us with their knowledge and experience. On the outset, I would like to thank Dipen Bhai and IPCA people also for sponsoring such a nice webinar. And at the last but not the least, I would like to thank all the participants who have joined us and sent us so many questions. We are very sorry not to attend to all those questions because of time constraint. Thank you once again, and I request Dipen Bhai to organize such webinars off and on. Thank you.
Sure, sir. Thank you, Dr. Amish. Thank you, sir. In fact, on behalf of IPCA Ophthalmology, I would like to express my gratitude to Dr. Uday Gajiwala and Dr. Amish, without whom this webinar would have not seen the light of the day. I also express my deep sense of gratitude to Dr. M.S. Ravindra, to Dr. Savitri Sharma, to Dr. Sashi Kumar, to Dr. Jacob, and Dr. Jagdeep, and Dr. Chandrasekhar for a wonderful talk. It was very nice, the kind of response that we have had. When I look at the administration panel, it is very, very encouraging, and we would be willing to support more such initiatives on behalf of IPCA Ophthalmology. And I would like to pledge our support for this. Dr. Jagdeep Kakadia, you can be rest assured, your 1 hour webinar is a commitment from our side. And
How many have joined? Can you tell us?
Yeah.
I think Dr. Uday and Dr. Amish would be able to be the right person to see it. But last figure which I seen was 432.
Very nice.
Good number. Good number. Congratulations to all.
It was worth it.
Yeah. So in fact,
Dipen Bhai, we request you to make us a part of this another webinar, Dr. Jagdeep Kakadia's webinar.
Yeah, sure,
we
sir.
would like to at least attend that.
No, we'll be very happy, sir.
You moderate it, Ramesh.
I wish him really luck that this methylene blue takes off and gets more attention than what it has got so far.
Dipen Bhai, there are more than 120 questions which have come.
Yeah.
Can we just save the questions so that we can reply them separately?
Absolutely. We'll do a follow-up webinar for answering those questions.
Okay, great.
Yeah,
Thank you
we
so
can have
much.
a panel and we can answer only, it would be no lectures and only answering the questions.
That's a great idea.
A panel discussion sort of thing. We can do
that's a
it
good
in
idea.
near future.
Sure.
Yeah,
I think
think,
all the speakers and panelists would agree to that, and with the same people we can just start
Just question
and
answers.
have these question answers. Yeah,
I'll
that's
be
a
very
good
happy,
idea.
sir. We can, even if the speakers agree, you can write answers and we can print a book, publish it, and subsequently share with ophthalmologist also. So
Yeah,
we
you
will
can send
actually,
us questions. That's possible.
right. We'll share it with you, sir. And Dr. Uday can share with me the next possible date where we can actually address the queries of the doctors also.
Yeah, I'll discuss the date in the group only so that everybody is comfortable with the dates. Most likely in a weekday, just like this, so that there are no clashes with other webinars.
Correct, sir.
We can continue with the same group.
Right.
It
sir.
will be the same group.
And Dr. Jagdeep, I promise a webinar to you, sir.
Stop the live streaming?
Thank you, ma'am.
Thank you.
Thank you.
Dr. Savitri, ma'am, my PG thesis was on efficacy of acetone as
I
a
saw the
disinfectant
chat,
for
yeah.
microsurgical instrument with Dr. John Elpar and Dr. Daljit Singh as guide and Dr. Anand Sudalkar. So since those days, I have been revering you because I read one of your paper on acetone.
I
And,
wrote it.
right. And वो 30 साल के बाद दर्शन हुए आपके आज.
Thank you so much, all of you.
Thank you so much, all of you. Dr. Chandrasekhar, you were also excellent, nice, and I wish you share your slides with us. That it was just superb, knowing lots and lots about masks.